First one by Dr. Anwar Al-Hulaybi about anatomy and pathophysiology of aortic valve disease. The second by Dr. Abi Al-Ghamdi about the latest aortic valve guidelines. We're supposed to have Dr. Yasser Al-Ghunaimi to join us in this session today, but unfortunately he has an emergency surgery, so he will not be able to join, but we will have Dr. Mazen Fatani instead. So I believe we'll have two more minutes to start. Dr. Anwar, you can prepare your slides if you don't mind. Thank you.
السلام عليكم.
عليكم السلام ورحمة الله.
أنا معكم الدكتور مازن فطاني جامعة الملك عبد العزيز. I'm just covering for Dr. Ghanem, who has an emergency. He might be joining us later, inshallah.
أهلا دكتور مازن. Thank you for joining us.
Thank you.
Dr. Anwar, you can start now. Thank you.
توفيق إن شاء الله.
السلام عليكم ورحمة الله. You can hear me?
Yes.
Yes, Doctor, I can hear you.
Okay. This is Anwar Al-Hulaybi. I'm cardiac surgery resident from Saud Al-Babtain Cardiac Center, Dammam. Today I will talk about the anatomy and pathophysiology of aortic valve disease. Before I starting my presentation, I would like to thank Dr. Mazen for joining us. Actually, Dr. Yasser called me before and he was in emergency, so Dr. Mazen will join us and Dr. also Fahad Makhdoom will join us later. So as an introduction, the aortic valve is a semilunar valve positioned at the end of the LVOT between the left ventricle and the aorta. A proper functioning of this valve is critical in maintaining efficient cardiac function. So the outline of this presentation is I will speak about the embryologic development of the aortic valve, the anatomy of the aortic valve, the mechanics of movement of the valve. Then I will talk about some of the diseases of the aortic valve, like aortic stenosis, regurgitation, and the bicuspid aortic valve. We will start with the embryology. The embryological development of the aortic valve is closely associated with the development of the LVOT. As we see here in the screen, that in the primary heart tubes, the blood travels from the primitive ventricles into the bulbous cordis, then into the aortic roots. And we see here that the mid portion of the bulbous cordis, which is called the conus cordis, develops into the LVOT or the RVOT, and the distal portion of this bulbous cordis, which is called the truncus arteriosus, will develop into the proximal portion of the aorta and the pulmonary arteries. So during the 5th week of development, pairs of opposing swellings appear in the conus cordis and the truncus arteriosus, as we see in here. Then these conotruncal or bulbal ridges grow toward each other and diffuse to form the aortopulmonary septum. This septum will divide the conus cordis into the left and right ventricular outflow tract, and the truncus arteriosus will be divided into the ascending aorta and the pulmonary trunks. So when partitioning of the truncus arteriosus is nearly completed, the aortic valve begins to develop from 3 swelling, as we see here. The 2 swellings will arise from the fused truncal ridges and will develop into the right and left cusp, and the 3rd swelling will develop into the posterior or the non-coronary cusp. The anatomy of the aortic valve. The normal aortic valve consists of 3 semilunar leaflets or cusp that projecting outward and upward into the lumen of the ascending aorta. So there is 3 cusps. The left coronary cusp, usually the smallest one, and the right coronary cusp, and the posterior or the non-coronary cusp, which is usually the largest one. And the spaces between the 3 edges of each leaflet and the points of attachment to the aorta will form the sinuses of Balsalva, as we see here in the picture. There is 3 sinuses of Balsalva. So the ostia of coronary arteries will arise from the upper part of the sinuses, in which the ostium of the left coronary artery is slightly higher than the right one. The leaflets are separated from one another at the aorta by commissures, and there is 3 commissures: the right left commissure, the right posterior commissure, and the left posterior commissure. At the center, the leaflets will meet at the line of the coaptation, and which will form what is called the nodules of Arrantius. So what is the relationship of aortic valve? The left posterior commissures is the left, as we see here. This is the left posterior commissure. Here, it will be here. The left posterior commissure is a fibrous continuity between the aorta and the mitral valve. And below the area, below this commissure, is the aortomitral curtain, which is an important anatomical landmark for aortic enlargement procedure. The right posterior commissure is positioned directly above the conduction system and the membranous septum. The right left commissure opposes the posterior commissure of the pulmonary valve, and the 2 associated aortic cusp opposes the right ventricular infundibulum. Because of the semilunar attachment of the leaflets, the aortic valve does not have a true annulus. Instead, the leaflets have a semilunar attachment along a hollow cylinder of tissue interconnecting the left ventricle chamber to the proximal aorta. So the distal border of this cuff is the sinotubular junction, which is an imaginary line connecting the commissures, and the proximal border is the ventricular arterial junction. And it is divided into 2. The hemodynamic junction, which is along the attachment of the leaflet, and the anatomical junction, which is marked by the circular attachment of the proximal aorta and muscular and the membranous septum. So how the aortic valve opens? We know that when there is pressure differences between the aorta and the ventricle, coupled with the compliance of the aortic root, this will cause aortic root dilatation and constriction during cardiac cycle. So this dynamic motion of the root itself plays an important role in the opening and closing of the aortic valve. So during late diastole, as blood fills the ventricle, 12% expansion of the aortic root occurs 20 to 40 milliseconds before aortic valve opening. Then the leaflet will begin to open as a result of root dilatation, even before any generation of positive pressure that results from the contraction itself. So root dilatation will be responsible about opening of the leaflet for 20%. So as pressure rises in the LVOT, there will be the tension between the leaflets will decrease. Then as pressure continues to rise, the tension itself in the leaflet will decrease. At the end, there will be no tension within the leaflet. So this loss of tension allows the aortic root to further dilate, and this will allow the valve to open rapidly at the beginning of the ejection. So under normal circumstances, the aortic valve presents little or no obstruction to flow because the specific gravity of the leaflet is equal to that of the blood. So this mechanism will permit rapid opening of the valve and minimal resistance to ejection. How the valve will close? Principal theory behind the closure of the aortic valve is the vortex theory, which recognizes the importance of the sinuses of Balsalva in valve closure. As ejection occurs, blood creates like a small eddy current along the aortic wall, as we see in this picture. Then at the end of the ejection, these currents will fill the sinuses of Balsalva, and this filling of the sinuses of Balsalva will push the leaflet away from the aortic root towards the aortic axis. Then after the pressure differences across the open aortic valve equalizes, a small flow reversal will force the leaflet to completely close. So the opposition of the valve leaflet occurs briskly and ensuring that the second heart sound will occur after complete closure of the aortic valve. Now we will start with the diseases of the aortic valve. We will start first with the aortic stenosis. Aortic stenosis, as you know, is incomplete opening of the aortic valve, which restricts the blood flow out of the left ventricle during systole. The prevalence and the etiology of the aortic stenosis in developed countries, AS is the most prevalent valvular heart disease in adults. Is more common in men, and its prevalence increasing with the age. It has been found that patients aged 65 to 75, 75 to 85, and more than 85, the prevalence of AS is 1.3%, 2.4%, and 4% respectively. The most common cause of AS are acquired degenerative disease, bicuspid aortic valve, and rheumatic heart disease, and we will speak about each one. First, we will start with the acquired aortic stenosis. The most common cause of aortic stenosis is degenerative calcification of the aortic valve, which typically occurs in the elderly. The progressive calcification initially will begin along the flexion lines at the leaflet bases, which will lead to immobilization of the cusp. And the characteristic pathological findings will be a discrete focal lesion on the aortic side of the leaflet that can extend deep into the aortic annulus. And this can involve also the sinuses of Balsalva and the ascending aorta as well. So it was thought that the calcification will be a result, or the degeneration will be the result of years of mechanical stress, leads to proliferation and inflammatory changes with lipid accumulation, upregulation of the angiotensin converting enzyme activity, and infiltration of the macrophage T lymphocytes in a process similar to the atherosclerosis. So the risk factor of aortic stenosis, calcific aortic stenosis, will be the same of the atherosclerosis, and this include diabetes, hypertension, cigarette smoking, and elevated LDL levels. Therefore, coronary artery disease is usually or commonly present in patients with AS. The bicuspid aortic stenosis. A calcific bicuspid aortic valve represents the most common form of congenital AS. It's usually present in approximately 1 to 2% of the general population, in which there will be a gradual calcification of the bicuspid aortic valve, which results in significant stenosis, most seen in the 5th and 6th decade, and mostly it is earlier in men than in women. The abnormal architecture of the valve itself, which it will induce turbulent flow, which injures the leaflet and leads to fibrosis, increased rigidity, leaflet calcification, and finally it will result in narrowing of the aortic valve orifice. The rheumatic aortic stenosis. In Western countries, the rheumatic AS represents the least common form of AS in adults. The rheumatic AS is rarely an isolated disease, and it usually occurs in conjunction with the mitral valve stenosis. Rheumatic AS is characterized by diffuse fibrous leaflet thickening with diffusion of one or more commissures. The progression of rheumatic AS is slower than of the degenerative calcific disease, in which in early stage of rheumatic AS, this will be characterized by edema, lymphocytic infiltration, and revascularization of the leaflet. However, in the later stage, there will be thickening, commissural fusion, and scarred leaflet edges. So what is the pathophysiology of the aortic stenosis? In adults with calcific disease, the aortic valve slowly thickens over time. Early, it will cause little hemodynamic disturbance as the valve area will be reduced from 3 to 4 centimeter square to 1.5 to 2 centimeters square. And past this point, hemodynamic significant obstruction of the LVOT will develop, and it will be associated with increase in LV pressure and lengthening of the LV ejection time. So as the LV pressure will be increased, this will lead to increased wall stress, which is normalized by increased wall thickness and will result in LVH. So as the ventricle will hypertrophize, the left ventricle becomes less compliant, and the left ventricular end-diastolic pressure will increase without chamber dilatation. And this will lead to diastolic dysfunction. Then the ventricle will become increasingly dependent on the atrial systole. So if the patient develops any atrial arrhythmias, he will decompensate rapidly. Although the LVH is adaptive, it has some adverse consequences, like increase in myocardial oxygen consumption due to LVH, increase the systolic pressure, and prolonged ejection time. It can also increase the systolic pressure, which will, the increased diastolic pressure increases the endocardial compression of the coronary arteries, which will reduce the coronary flow reserve. And also the prolonged ejection can also result in decreased time in diastole, and therefore reduced myocardial perfusion time. So the increased demand of the hypertrophied ventricle and decreased delivery capacity can result in subendocardial ischemia with activity, resulting in angina and LV dysfunction. In later stage of severe AS, the left ventricle will start to decompensate with resulting dilated cardiomyopathy and heart failure. Cardiac output will decline, then the pulmonary artery pressure will rise, resulting in pulmonary hypertension. And the myocardial hypertrophy in patients with AS is characterized by increased gene expression for collagen 1, 2, and fibronectin that is associated with the activation of the renin-angiotensin system. the hemodynamics of AS. The severity of AS can be assessed by measuring the aortic valve area, the mean pressure gradient, and the peak jet velocity. There is what is called effective aortic valve area and anatomical aortic valve area. The effective one is calculated using the continuity equation, as we see here, and which is based on the concepts that stroke volume through the LVOT and the aortic valve are equal. Although the effective aortic valve area is smaller than the anatomical area, it is a reliable predictor for a clinical outcome and is generally used in clinical decision making. The anatomical aortic valve, on the other hand, is calculating using the Gorlin formula, which describes the fundamental relationship that link the area of an orifice to the flow and the pressure drops across that orifice. And it's usually depend on the cardiac output, which can be measured by the FIC or the thermodilution measurement. As we see, this is the equation, the Gorlin formula. The transvalvular pressure gradient can be measured by simultaneous catheter pressure measurements in the left ventricle and the proximal aorta. The peak-to-peak gradient, measured as the difference between the peak LV pressure and the peak aortic pressure, is used commonly to quantify the valve gradient. However, the invasive measurements of the aortic stenosis severity has been replaced by the measurement using the echo, which is currently the clinical standard. And the gradient can be calculated from the Doppler acquired the VTI of the aortic valve using the Bernoulli equation, in which the gradient is equal to the pi of the VTI of the aortic valve and we square it then. The TE is an alternative method for assessment of the aortic valve area that uses the planimetry of the systolic short axis view of the aortic valve, and it is only recommended when the Doppler estimation of the flow velocities is unreliable. What is the symptoms of aortic stenosis? The cardinal symptoms are angina pectoris, syncope, and symptoms of congestive heart failure. A common theory for the syncope development is that the augmented stroke volume that usually accompanies exercise is limited by the narrowed outflow orifice. So with exercise-induced reduction in peripheral arterial resistance, the blood pressure will drop, leading to cerebral hypoperfusion and syncope. And this may, it can also due to dysfunction of the baroreceptor mechanisms. Baroreceptor mechanism and the vasodepressor response to the increased LV systolic pressure during exercise. Beside the cardinal symptoms, some patients will develop fatigue and decrease exercise tolerance. And a rare representation of aortic stenosis is a gastrointestinal bleeding secondary to angiodysplasia that occurring predominantly in the right colon or in the small bowel or stomach. And these abnormalities will correlate with the severity of AS and are correctable by aortic valve replacement. Other late manifestations of severe AS include AF and pulmonary hypertension, and sometimes infective endocarditis can occur in younger patients with AS. And it is less common in elderly patients with severely calcified valve. What is the natural history of aortic stenosis? Patients who develop severe AS have a long period of asymptomatic progression in which morbidity and mortality is relatively low. So sudden death from AS before the onset of symptoms is estimated to be around 1% per year. However, if the symptoms started, the mortality rate jumps to 25% per year without surgical intervention. Here we can see in this diagram that if the patient develops angina, so the mean survival, the mean survival will be for 5 years, and the mean survival for patient who developing syncope will be 3 years, and the mean survival for patient developing congestive heart failure symptoms will be 2 years. What is the signs of AS? The classic signs of aortic stenosis is systolic crescendo decrescendo murmur. Other signs can include delayed second heart sound due to the prolongation of systolic ejection time, pulsus parvus, which means small pulse, and this is due to falling of the pulse pressure, systolic pressure, and falling of stroke volume. Pulsus tardus, which is a late pulse, which is and it is also due to the prolongation of the ejection time. If there is an LVH, we can feel apical thrust or heave, and on the central venous wave, we can see a prominence of the A wave due to decreased the right ventricular compliance due to the development of RVH, and this is in later stages. ECG, sometimes we can see some ECG changes in patients with the LVH, and the conduction abnormalities may result from hypoxic damage of the conduction fibers or from extension of the calcification into the fibrous septum. Chest X-ray, it's usually normal in patients with AS with compensated aortic stenosis. However, and sometimes we can see in the chest X-ray post-stenotic dilatation of the aorta and calcification of the aortic valve cusp. And in decompensated AS, we can see cardiomegaly and some pulmonary congestions. Echo is the diagnostic tool of choice for confirming the diagnosis of AS, and it can also help in assessing the severity and the etiology of AS, assessing if there is any valvular, other valvular abnormalities, and to assess the LV chamber size and function. And according to the echo, the AS can be classified into mild, moderate, and severe, according to the valve area, the mean gradient, and the peak velocity. If the peak velocity is more than or equal 4, the mean gradient is more than 40, and the valve area is less than 1, so this is severe AS. Exercise testing usually should be avoided in symptomatic patients, and it is considered a relative contraindication in severe AS. Dobutamine stress echo can be used in cases of low flow, low gradient aortic stenosis to assess the contractile reserve. And we will speak about this later. Cardiac catheterization is recommended when non-invasive tests are inconclusive or there is a discrepancy between non-invasive tests and the clinical findings to determine the severity of AS. However, it remains the gold standard for measuring the transvalvular gradient. As we said, the coronary artery disease is common in patients with AS, so these patients should be evaluated prior to any intervention. Especially if the patient is having angina, evidence of ischemia, history of coronary artery disease, or coronary risk factor, to assess if the patient is needing myocardial revascularization besides AVR. CT is the only non-invasive modalities that provide direct assessment of the amount of aortic valve calcification. ECG-gated multi-detector CT has a high accuracy and in quantifying the calcification and its progression and estimation of the area itself by the planimetry. CT is useful in patients who are going to do a TAVI to assess the valve annulus, leaflet length, annular to coronary ostial distance, and also to assess or evaluate the prosthesis after deployment. MRI has emerged as an alternative non-invasive imaging modality for AS. MRI is useful when the acoustic windows in the echo are poor or there are discordance imaging and catheterization results. I will talk about the general concepts of management because in the second lecture we will talk about the guidelines. So there is no effective medical therapy for AS. The definitive treatment for AS is replacement, aortic valve replacement, and the onset of symptoms is the primary indication for surgery. Management of congestive heart failure from AS has traditionally consisted of diuretics and inotropes. Beta blockers should be avoided as it will reduce the contractility, which leads to decreased cardiac output in an overloaded ventricles. Vasodilators are avoided in AS because their administration can lead to hypotension, and this can result in syncope and reduce the coronary perfusion. However, in patients with AS and decompensated heart failure and also severe LV systolic dysfunction, vasodilators may improve the cardiac function and it's used as bridge to replacement. TAVI is a viable option for treatment of severe AS in patients who are at high risk of surgical AVR. Percutaneous aortic balloon dilatation is ineffective as most valves tend to restenose, and currently it is indicated as bridge only to TAVI or AVR, surgical AVR, in severely symptomatic patients with severe AS. In asymptomatic patients, the general indication are worsening of hemodynamic parameters. The ejection fraction is less than 50, the velocity is more than or equal 4, and the mean gradient is more than or equal 40. If there is decreased systolic opening of calcific valve, if there is cardiac surgery, if the patient is undergoing cardiac surgery for other causes, and he has low surgical risk, and there is also decreased exercise tolerance on the exercise stress test. There are 4 categories of aortic stenosis. High gradient aortic stenosis in which the area is less than 1 and the gradient is more than 40. So this is considered severe AS irrespective to the ejection fraction. There is the second one is the low flow, low gradient AS with reduced ejection fraction in which the area is less than 1. And mean gradient is less than 40, ejection fraction less than 50, and the stroke volume index is less than or equal 35. So in these cases, low dose dobutamine echo is recommended to distinguish a truly aortic, severe aortic stenosis from the pseudo-severe aortic stenosis. The pseudo-severe aortic stenosis will be increased in which there will be an increase in the aortic valve area more than 1 with the flow normalization. The third one is the low flow, low gradient aortic stenosis with preserved ejection fraction in which the area is less than 1, the gradient is less than 40, the ejection fraction is more than or equal 50, and the systolic stroke volume index is less than or equal 35. So this is typically encountered in elderly patients and is associated with a small ventricular size, marked LV hypertrophy, and frequently a history of hypertension. So in these cases, multi-slice CT scanning is recommended to see or to evaluate the degree of valve calcification. The fourth one is the normal flow, low gradient aortic stenosis with preserved ejection fraction, in which the area is less than 1, mean gradient less than 40, and the ejection fraction is more than or equal 50, and the stroke volume index is more than 35, and this is called moderate aortic stenosis. Any question in aortic stenosis? Okay, I will start with the aortic regurgitation.
Can I add something, Anwar? Don't mind?
Yes.
Yes, regarding the symptoms, it's just a small addition for aortic stenosis, the cardinal symptoms, the angina and the syncope and heart failure. Even though these are the cardinal symptoms, but actually they represent the later stages of the disease process of aortic stenosis. So
Yes.
ideally, we should diagnose patients before these symptoms, because as you said in one of your slides, these symptoms are associated with higher risk of mortality.
Yes,
That's
and
it.
the beginning of the symptoms is the primary indication of surgery also.
Yeah, but we shouldn't wait for these three, because these are actually later. Because sometimes patients have decreased exercise tolerance, but they adjust for this decrease of exercise tolerance. So they will say that we don't have symptoms, while actually instead of going 2 floors, they would go now 1 floor. They only just adapted for this decreased tolerance.
Okay.
Okay, thank you.
Thank you. Okay, I will start with the aortic regurgitation now. Aortic regurgitation, as you know, that it is a diastolic reflux of blood from the aorta into the LV due to failure of coaptation of the valve leaflets at the onset of the diastole. AR may be caused by primary disease of the aortic leaflets and or diseases of the aortic root. The primary diseases of the leaflet themselves can be caused by aortic leaflet calcific degeneration, myxomatous degeneration, infective endocarditis, rheumatic disease, bicuspid aortic valve, or some medication that can affect the leaflet. Aortic root dilatation can be caused by dissection, trauma, chronic systemic hypertension, some infections in the aorta, and some connective tissue disorders. Aortic regurgitation is seen most commonly in combination with AS due to calcific or rheumatic disease, in which some degree of aortic regurgitation is present, and it's usually mild. In patients with a pure AR undergoing aortic valve replacement, the regurgitation secondary to aortic dilatation is now more common than the primary valve leaflet. The pathophysiology of AR. The pathophysiology of regurgitation varies according to the onset and the duration of the disease process. So we will start with the acute aortic regurgitation. Acute AR is a significant aortic incompetence of sudden onset across a previously competent aortic valve. So acute AR is typically caused by aortic dissection, endocarditis, or trauma. So as blood returns to the left ventricle and diastole, it will cause a sudden increase in the left ventricle and diastolic volume, and it will reduce the effective or forward stroke volume. So the left ventricular and diastolic volume will increase only 20 to 30%, because the compliance of the ability of the LV to dilate is acutely limited, which leads to a rapid increase in the left ventricular and diastolic pressure. Once the end diastolic pressure is increased, this will result in increase in the left atrium pressure, and this will lead to pulmonary venous pressure. The pulmonary venous pressure will also increase, and this will reduce pulmonary edema. The rapid rise of the end diastolic pressure also blunts or abolishes the normal widened pulse pressure that is seen usually in chronic aortic regurgitation. So in the acute setting, the maintenance of an appropriate effective cardiac output will depend on two compensatory mechanisms. First one is the increase in the heart rate, and the second one increase in the contractility, as it is attributable to the Frank-Starling mechanism. The chronic aortic regurgitation. Chronic AR is a slow, insidious process which sets in motion numerous compensatory mechanisms. So, in a chronic type, the acute regurgitation will increase the left ventricular and diastolic volume. The and this will increase the left ventricular and diastolic pressure and will lead to eccentric hypertrophy of the left ventricle. So chamber enlargement with normal systolic function will increase the total stroke volume and maintains the forward stroke volume, in which the forward stroke volume is equal to the total stroke volume minus the regurgitant volume. The increase in total stroke volume coupled with the normal or slightly elevated left ventricular and diastolic pressure is responsible for the wide pulse pressure, which is usually seen in patients with a chronic AR, and it is usually the main reason for most of the signs of the patient with a chronic AR. The forward stroke volume in aortic regurgitation is increased by any physiological changes that decreases the afterload or increases the heart rate. So increasing the heart rate will increase the forward stroke volume. However, it will decrease the diastolic filling time, and hence the regurgitant flow time and volume will also decrease. The peripheral vasodilatation and increased heart rate that a combined exercise will increase the forward stroke volume in this manner also. So bradycardia and the use of negative chronotropic agents should be avoided in these patients. As aortic regurgitation progresses, the hypertrophic response becomes inadequate and the preload reserve is eventually exhausted. So at this time, heart failure will occur. The myocardial ischemia can also happen in aortic regurgitation, and it can be resulting from both decreased coronary artery perfusion and increased the myocardial oxygen demand. And this one is due to increase the LV mass, wall tension, and the increase in systolic ventricular pressure. So superimposed coronary artery disease only exacerbates the effect of decreased diastolic coronary perfusion pressure, and the subsequent ischemia caused by decreased perfusion and increased oxygen demand can lead to cell death and fibrosis, and this will contribute eventually to systolic dysfunction. What are the symptoms of AR? The presentation varies depending on the onset, severity of regurgitation, compliance of the ventricle and the aorta, and the hemodynamic condition that is present at the time. Acute AR can be life-threatening if not treated emergently, whereas chronic AR is usually well tolerated for years. In severe acute AR, it usually presents with sudden cardiovascular collapse, and the patient will often present with ischemic chest pain caused by decreased coronary blood flow, coupled with the rapidly increased myocardial oxygen demand. Patients with chronic compensated AR, they remain asymptomatic for a prolonged period of time, while the left ventricle gradually enlarges. Symptoms of heart failure, such as exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, usually develops gradually only after considerable LVH and decompensation. Patients with severe AR may experience palpitation during emotional stress or exertion, angina pectoris, nocturnal angina, or atypical chest pain syndrome due to pounding of the heart against the chest wall. The signs of AR, physical examination findings vary with the chronicity of the disease process. And many of the signs, as we said, it is a result from the wide pulse pressure, and this can include what is called the Corrigan pulse, which is a rapid and forceful distension of the arterial pulse with a quick collapse, and this is usually seen in the carotid arteries. This quick collapse is partly due to two causes. It is due to sudden fall in diastolic pressure in the aorta, which is due to the regurgitation of the blood from the aorta into the left ventricle through the leaky valve. And the second cause is due to the rapid emptying of the arterial system. And this phenomena can be seen also by asking the patient to raise his arm and palpating the radial artery, and this is called water hammer pulse. There is what is called the Demoseb sign, which is a head bobbing with each heartbeat. So it will be like a bird walking. The other sign is the Quincke pulse, which is a capillary pulsation in the lips and fingers. There is what is called pulsus bisferens, which is, as we see in this picture, is a single pulse with two peaks in the systole, and it's usually resulted from a rapid ejection of blood during systole, and is thought to draw the walls of the aorta together due to the Venturi effect, and temporarily will decrease the blood flow in the aorta in the mid-systole. There is what is called molar sign, which is a visible pulsation of the uvula. And all these are the result from the wide pulse pressure that is seen in a chronic AR. And the classical auscultatory findings of aortic regurgitation is an immediate or early diastolic blowing decrescendo murmur. And if the aortic regurgitation is caused by the root disease, the murmur will be heard along the right sternal border. There is what is called the Austin Flint murmur, which is in which if the regurgitant jet striking the anterior leaflet of the mitral valve, this will lead to a premature closure of the mitral valve. So this will be mistaken as the patient is having an MS, and this is what is called Austin Flint murmur. If the patient is having congestive heart failure, we can auscultate rails and S3 sounds. So in acute aortic regurgitation, as the pulse pressure is not widened, the signs of chronic AR are not seen. Instead, signs of congestive heart failure will be predominant in acute setting. The ECG is an accurate predictor of aortic regurgitation severity, but sometimes we can see ECG changes due to LVH, and sometimes there will be an LV conduction defect occurs late in the course and are usually associated with the LV dysfunction. Chest X-ray is usually normal, and if there is an aortic disease, the aorta, we can see the aorta is dilated in cases of acute AR. Echo is the most useful diagnostic modality in both initial diagnosis and monitoring of patients with AR. And the transthoracic echo is the most commonly used imaging modality. It can help, it provides a non-invasive assessment of aortic valve and aortic anatomy. We can assess the presence, the severity, and the etiology of the regurgitation and the size and the function of the left ventricle also. So by echo, the aortic regurgitation can be classified into mild, moderate, severe, depending on the jet width, the vena contracta width, the regurgitant volume, the regurgitant fraction, and the regurgitant orifice area. If the vena contracta width is more than 0.6, if the regurgitant volume is more than or equal 60, and the fraction is more than or equal 50, and if the orifice area is regurgitant orifice area is more than or equal 0.3, this is considered as severe AR. Transesophageal echo is used when a patient's body habitus does not allow for adequate assessment with the transthoracic echo and to evaluate the aortic valve and the ascending aorta in patients with suspected aortic stenosis. Additional echo findings in AR we can see, as we said, that sometimes there will be premature closure of the aortic of the mitral valve due to diastolic flattering, most commonly of the anterior mitral leaflet, but less commonly the diastolic flattering can happen to the posterior mitral leaflet as well. Exercise stress testing, it can provide valuable information in patients with AR, especially in those whose symptoms are equivocal or difficult to assess. And in the management of AR, the presence of symptoms with exercise testing is equivocal to the symptoms at rest, as both of them warrant aortic valve replacement. Cardiac catheterization is most commonly used during pre-op assessment for coronary anatomy in patients with patient requiring aortic valve repair or replacement. And the amount of regurgitant flow can be determined by calculating the angiographic stroke volume minus the measured fixed stroke volume, in which the differences between these two measurements divided by the angiographic stroke volume will determine the regurgitant fraction. Left ventricular and diastolic pressure can also be directly measured by cath, and the ejection fraction is roughly estimated. The CT and MRI. CT can be used to assess the severity of AR by measurement of the regurgitant orifice area, but currently the results of the CT are inferior to the echo. MRI cine angiography is able to provide some of the same information provided by the transthoracic or the transesophageal echo. MRI in some aspects provide a superior resolution of the valve and better quantification of the regurgitant flow and the left ventricular function. However, MRI is costly and the expertise is not available in most centers, so it is usually not used. This is the recent classification of aortic regurgitation. I will skip this because we will talk about this in the second lecture. The management of AR, the surgical option for aortic regurgitation are either repair or replacement. The repair is preferred over the replacement due to longer durability, equal short-term and better long-term survival, and there will be no added risk of prostatic valve complication. So when visible, aortic valve repair should be attempted prior to performing the replacement. Patients with aortic regurgitation associated with ascending aortic aneurysm can undergo valve-sparing aortic root replacement, and effort is made to preserve the natural aortic valve to avoid the need for long-term anticoagulation and reduce the risk of stroke. So compensated chronic AR is well tolerated by most patients, and the current recommendation for the management of chronic aortic regurgitation depends on the presence of the symptoms, the left ventricular function, and the LV dimensions. Medical management of patients with a chronic AR and hypertension consists of calcium channel blocker or ACE or ARBs. Beta blocker are only indicated for patients with severe AR who are not candidates for surgical interventions with symptoms of LV, with symptoms or the presence of LV dysfunction. This is the recommendation. I will skip this also because we will speak about it in the next lecture. Acute AR is treated by early aortic valve repair or replacement depending on the etiology. So with an inadequate time for the left ventricle to compensate by eccentric hypertrophy, progressive congestive heart failure, tachycardia, and diminished cardiac output will occur rapidly. So vasodilators and inotropic agents, which can augment the forward flow and reduce the left ventricular and diastolic pressure, may be helpful in the management of these patients as a bridge before surgery. So after surgery, left ventricular and diastolic volume and the left ventricular and diastolic pressure will decrease significantly, and with the decrease in the preload, the ejection fraction also will decrease. So the LV size and function eventually will return to normal if the operation is timely corrected. And the best post-operative predictor of recovery in the function is the reduction of the left ventricular end-diastolic diameter. It has been found that 80% of the total reduction in the left ventricular end-diastolic diameter after ABR will occur within 10 to 14 days after surgery. Additional changes that will occur post-operatively include regression of the myocardial hypertrophy, normalization of the mass to volume ratio, increase in diastolic coronary perfusion, and there will be decrease in peak systolic wall stress. However, in some patients, despite surgery, LV dilatation or impaired the function may continue. And the best predictor of persistent LV dilatation are the higher preoperative left ventricular and systolic diameter. In addition to this, a greater pre-op left ventricular and diastolic diameter and the duration of LV dysfunction and the reduced ejection fraction can also predict the persistence of LV dysfunction. So the predictor for the development of future symptoms or LV dysfunction or even death can include the age, higher left ventricular and systolic volume, and higher left ventricular and diastolic volume, and ejection fraction during exercise. But it is this ejection fraction during exercise is insufficient evidence because ejection fraction during exercise is dependent on many factors, such as myocardial contractility, the severity of volume overload, and the exercise. And the exercise-induced changes in the preload and the pulmonary vascular resistance as well. Any question in the aortic regurgitation, or I can move to the bicuspid aortic valve? Okay, the final topic is the bicuspid aortic valve. The bicuspid aortic valve is one of the most common types of congenital heart disease. As I said before, it can occur in 1 to 2% of the patient with a male to female ratio of 2 to 1 or 3 to 1. There is a strong genetic component to the bicuspid aortic valve disease, as it can occur sporadically or as an autosomal dominance with a variable penetrance. It can also occur as an isolated lesion, or it can be associated with other congenital cardiovascular defects. It has been found that mutation in the NOTCH1 gene associated with familial and non-familial bicuspid aortic valve and can also result in aortic aneurysm and early aortic calcification. It has been found also that mutations of other genes like the GATA5, the GATA6 have been also associated with the bicuspid aortic valve. Bicuspid aortic valve may develop significant aortic regurgitation and or stenosis, and it will be the bicuspid aortic valve itself is a risk of infective endocarditis. The bicuspid aortic valve patients often have aortic root or ascending aortic dilatation, with the prevalence of the aortic enlargement increasing with the age. So the bicuspid aortic valve is a risk factor for aortic aneurysm or even acute aortic dissection. There are some syndromes that are associated with the bicuspid aortic valve and ascending aortic aneurysm, which include Turner syndrome, in which the bicuspid aortic valve is presenting in 30% of the cases, the Loeys-Dietz syndrome, in which the bicuspid aortic valve presenting in 2.5 to 17% of the cases, and the familiar thoracic aortic aneurysm syndromes, in which the bicuspid aortic valve has been found in 3% of the patients. Furthermore, coronary artery anomalies are associated with the bicuspid aortic valve. and it has been observed that the left coronary artery dominance is more common in bicuspid aortic valve patients, and short left main coronary artery is also seen with bicuspid aortic valve. This table showed some of the cardiovascular conditions that can be associated with the bicuspid aortic valve. As we see that ascending aortic aneurysm is very common, and the shown complex can be presenting in 60 to 85% of the patients. Valve anatomy of the bicuspid aortic valve. The anatomy of the bicuspid aortic valve includes unequal cusp size due to the fusion of two cusps, which will produce the larger cusp, and a raphe, which is a ridge. Sometimes it's called like a fibrous ridge, which is the side of the fusion of the two conjoined cusps. And there is also smooth cusp margins. The bicuspid aortic valve is classified into three types: type 0, type 1, and type 2. Type 0, in which there is two aortic sinuses and no raphe, and this is called the true bicuspid aortic valve. Type 1 is the most common form, and in which it has one raphe, and the right and left leaflet fusion are the most commonly seen, and the right and non-coronary leaflet fusion occurs in 15% of the patient, and the right and left and non-coronary leaflet fusion is the least common form of this type. Type 2, in which there is two raphe, and it is functional. It is called functionally unicuspid aortic valve. It's present in only in 5% of the patients. Leaflet orientation may affect the valve function with the fusion of the right and non-coronary leaflets, and it's associated with the greater valvular dysfunction. Calcification of the bicuspid aortic valve increases with the age and occurs more rapidly than it's seen with the tricuspid valve. There is an abnormal leaflet motion and turbulence during cardiac cycle due to the architecture of the valve, and this may play a role in premature degeneration of the valve. We will start with some of the diseases of the bicuspid aortic valve. Aortic stenosis, in which in autopsy series, aortic stenosis was present in up to 75% of the bicuspid aortic valve. And in surgical series, about 50% of the aortic stenosis that's leading to AVR in adults is due to bicuspid aortic valve stenosis. Leaflet morphology and atherosclerosis risk factors play a role in progression of the aortic stenosis. In children, it has been found that right and non-coronary leaflet fusion is associated with stenosis. However, in adults, the fusion of the right and left coronary cusp is associated with more rapid aortic stenosis. The stenosis of the bicuspid aortic valve will require surgery in average 5 to 10 years earlier than it has been seen with the tricuspid aortic valve stenosis. Aortic regurgitation, isolated aortic regurgitation complicating the bicuspid aortic valve is less common than the aortic stenosis, and it's affecting in up to 10% of the patient. Mixed stenosis and regurgitation are often present, and pure aortic regurgitation is more commonly seen in younger patients, as some degree of aortic stenosis coexists in older patients. So the mechanism of regurgitation in the bicuspid aortic valve can include leaflet abnormalities, leaflet thickening and immobility, endocarditis, aortic root and annular dilatation with loss of the valve support, aortic dissection and post-valvoplasty, and it is most commonly seen for congenital aortic stenosis. The third one is the aortic dilatation and aortic dissection. Aortic dilatation in bicuspid aortic valve may affect the aortic root and or the ascending aorta, and is usually largest in the mid-ascending aorta. The rate of dilatation increases in older adults with bicuspid aortic valve. The reported prevalence of aortic dilatation in patients with bicuspid aortic valve has ranged up to 84%. It is related to an underlying aortopathy with cystic medial degeneration, hemodynamic effect of the bicuspid aortic valve, and an underlying genetic defect. There are 3 patterns of aortic dilatation in the bicuspid aortic valve. Type 1, in which there will be a dilatation of the ascending aorta, and there is mild to moderate dilatation of the root itself. And this is the most common type, and it is usually associated with right and left cusp fusions and aortic stenosis also. Type 2 is an isolated ascending aorta dilatation in which there is a sparing of the aortic root and usually associated with the right and non-coronary cusp fusion. Third type is called the root type, which is in which there is an isolated root dilatation, and this is the rarer type, and it is usually common in younger patients, and it has some genetic factors. Aortic dissection. The risk of aortic dissection in bicuspid aortic valve increases with a greater degree of aortic dilatation. It has been estimated that aortic dissection occurs 5 to 10 times more commonly in patients with bicuspid as compared to a tricuspid valve. The clinical manifestation of aortic stenosis. The clinical findings of bicuspid aortic valve depends on the function of the valve and the presence of associated lesions. So the initial presentation of the bicuspid aortic valve is variable, with many patients kind of presenting with asymptomatic auscultatory findings, in which the functionally normal bicuspid aortic valve can produce an ejection murmur or a click. Moreover, if the patient is having bicuspid stenosis or regurgitation, they can present with the symptoms of these diseases. And also if the patient is having bacterial endocarditis or with evidence of an aortic root or ascending aortic aneurysm, or they can present after acute aortic dissections. The physical examination should include a careful arterial pulse examination to exclude coarctation of the aorta, which can occur with the bicuspid aortic valve also. When aortic aneurysm is present, especially involving the aortic root, it is important to evaluate the patients for features of an underlying aortopathy syndromes. So how we can diagnose bicuspid aortic valve is by the transthoracic echo, in which transthoracic echo has a sensitivity up to 92% and specificity up to 96% for detecting bicuspid aortic valve. However, the accuracy depends on the image quality, valve calcification, the presence of the aneurysmal disease, and the experience of the interpreter. And in patients with non-bicuspid aortic valve, transthoracic echo is indicated to evaluate the valve morphology, measure the severity of AS and AR, assess the shape and diameter of the aortic sinuses and the ascending aorta, and evaluate for the presence of aortic coarctation, and this is a class 1. Findings of bicuspid aortic valve in echo can include systolic doming, as we can see in this picture. Here there is a doming of the leaflet itself during systole, and eccentric valve closure, leaflet redundancy, leaflet prolapse, the presence of Arafi, elliptical orifice of the valve during systole, and dilated aortic roots and or ascending aorta. The evaluation of the valve itself should be done in the systole, because the Arafi may stimulate tri-leaflet appearance during the diastole. When unexplained aortic dilatation is discovered and the bicuspid aortic valve is not completely excluded by the echo, by the transthoracic echo, the TEE or MRI can be used. And in patients with bicuspid aortic valve, cardiac MRI or CT angiography is indicated when the morphology of the aortic sinuses, the sinotubular junction, or the ascending aorta cannot be assessed by the echo, and this is class 1 indication. So how we can manage the patient with the bicuspid aortic valve? To enable timely intervention, all patients with bicuspid aortic valve should be monitored for a progressive aortic valve dysfunction, thoracic aortic dilatation, aneurysmal formation, and aortic dissection. In patients with bicuspid aortic valve and a diameter of the aortic sinuses or ascending aorta of more than or equal 4 centimeter, lifelong serial evaluation of the size and the morphology of the aortic sinuses, the ascending aorta by echo, cardiac MRI, or CT angiography is reasonable, and this is a class 2A indication. In patients with bicuspid aortic valve who have undergone AVR, continued lifelong serial interval imaging of the aorta is reasonable if the diameter of the aortic sinuses or the ascending aorta is more than 4 centimeter, and this is also class 2A indication. In the first degree, relatives of patients with non-bicuspid aortic valve, a screening with transthoracic echo might be considered to look for the presence of bicuspid valve or asymptomatic dilatation of the aortic sinuses and the ascending aorta. And this is class 2B. The pharmacological therapy of bicuspid aortic valve. No drugs have been found to alter the natural history of bicuspid aortic valve disease or the aortic stenosis more generally. However, if hypertension presents, it should be treated according to the standard guidelines. So for patients with bicuspid valve, chronic aortic regurgitation, and systemic hypertension, vasodilatation such as ACE, ARBs, or calcium channel blockers are favored since they may reduce the systolic blood pressure in this setting. Beta blockers may be less effective in this setting. However, for patients with bicuspid aortic valve and dilated aortic root or ascending aorta without hypertension, there are no pharmacological therapies proven to lessen the aortic dilatation or lessen the risk of aortic dissection or rupture. But some clinicians use beta blocker in this setting because it has been suggested that usage of beta blocker have an advantage in reducing the aortic wall stress, which may reduce the rate of the progression. Endocarditis prevention. Although the patient with bicuspid aortic valve is at risk for endocarditis, antibiotic prophylaxis is not recommended for isolated bicuspid aortic valve. So good dental care and oral health practices are recommended in these patients. The intervention. The most common indication for surgical intervention in patients with bicuspid aortic valve is aortic stenosis. Surgical intervention timing of bicuspid aortic dysfunction should be follow the current valvular guidelines. Like if there is aortic sinuses or the ascending aorta is more than 5.5 centimeter, the replacement of the sinuses or the ascending aorta is a class 1. And if the sinuses or the ascending aorta is between 5 to 5.5 centimeter with risk factors for dissection, like if the patient is having family history of aortic dissections, if the aortic growth rate is more than or equal 0.5 centimeter per year, or there is a presence of aortic coarctation, so the replacement is class 2A. And if the sinuses or the ascending aorta is between 5 to 5.5 without any risk factors for dissection, so it is a class 2B for the replacement. And if the patient is having indication for surgical AVR and the aortic sinuses or the ascending aorta is more than 4.5 or equal 4.5 centimeter, so the replacement is a class 2A. This is my references, and I have some questions if you are willing to answer them. Do you have any question for me?
Well, excellent presentation, and we're very well prepared, and I thank you for a very thorough review for the aortic valve. Let's hear the questions from the audience. and then hear
Yes.
your questions, and then I'll go with my questions and maybe some additions to your excellent talk. So if anyone has a question or a burning question, please go ahead. I intentionally didn't want to interrupt you, so everyone is focused and the presentation doesn't take too long. So now it's a time for active discussion and having questions.
I have a question, if you don't mind.
Hold
The bicuspid aortic valve, should we consider it as a normal variance or as a congenital anomaly?
I think it is considered as a congenital anomaly.
Yes, it is a congenital anomaly. It is the most common congenital anomaly with 2%,
Yes.
or most common aortic valve anomaly. 2% of normal population will have a bicuspid aortic valve.
Okay, thank you.
Okay, any other questions?
طيب دكتور أنوار يعطيك العافية. Nice presentation. So I have, if you have a patient with bicuspid aortic valve and he has indication for surgery, what other imaging modalities or other thing I have to look at or exclude before surgery?
He has indication for aortic valve replacement or what?
Yes, for example, aortic stenosis.
Okay, I will request, I will review the echo that is done, and I will request CT scan to see the diameter of the aortic root and the aortic sinus. If it is more than 4.5 and there is indication for aortic valve replacement, it is a class 2A to replace or the aortic root and the ascending aorta or the sinuses itself.
Okay, and
Well,
do we need to look for... تفضل دكتور.
Yeah, you wouldn't CT scan every patient who needs an aortic valve procedure. Echo is usually enough to give you an indication of the size. If there is a dilatation, most of the patients you will have a good view of the root and the ascending aorta. And you only CT scan if there is an aortic dilatation. So you want to see the extent, you want to plan your surgery and all this. You want to see if there's an arch involvement, where does the aneurysm. So you want to delineate more the anatomy of the dilatation. But if there's no dilatation, you wouldn't go for a CT scan unless there's another indication. So imaging only if there is a documented dilatation on the echo. Or let's say the echo, you can't see the aorta for some reason, it's not echogenic, you can't, then you either do a TEE or you do a CT scan. But most of the patients, you will have a good view and an idea about the size of the aorta.
طيب دكتور, do I need to look for coarctation or perianeurysm in the brain? Is it like routine? I have to exclude it before surgery, or I just go with the clear indication?
What do you think, Anwar?
I think it is not done in all patients. If there is risk factors and if the patient is susceptible, we can do it.
Yes, I agree. So if there are signs indicating there's coarctation or suspicion, then yes, you look for it. Brain aneurysms, no, they don't usually coexist. So you don't need to look for brain aneurysms in bicuspid or ascending aortic aneurysm patients.
Okay, thank you, Doctor.
So any other questions?
Yes, thank you, Dr. Anwar, for this excellent presentation. Thank you, Dr. Mazen, for supervising this presentation. Dr. Anwar, you said that the risk of the LV function not regaining its normal function after surgery for aortic regurg is higher when there is a severe dilatation. Do you have numbers like, do you have numbers like when we should not interfere with this aortic regurg?
Up to my knowledge, that if the left ventricular end systolic diameter is the most predictor of LV dysfunction post-op, And I think it is more than 50, I think, or 60, but I'm not sure about the numbers. Yeah.
No, more than 50 is an indication to intervene.
Indication, yeah. It is an indication, yeah.
No, my question is there a number for severe left ventricular dilatation that will make us hesitant to take this patient to OR?
I'm not sure.
So I think as you dilate more, your ejection fraction or contractility are expected to be worse. So it's not going to be too dilated, and you have a good contractility and ejection fraction. So I think here it goes to how bad the contractility is. I don't think there is an exact number of dilatation or ejection fraction not to intervene. I think if the ejection fraction is severely depressed, so an ejection fraction below 20%, it can affect your decision. So if the patient is young, you may give him the benefit of doubt. If it's a little older, you go for more palliative procedure or palliative treatments or no surgery. But I think your goal here is to assess the LV function, not the dilatation more, and it does come with the dilatation. So if it's severely depressed, I think you should reconsider. So if the patient is ejection fraction is 15%, I don't think this is expected to recover. However, if the patient is young, not very symptomatic, you can give him the benefit of doubt, but then it may affect your decision on the surgery, whether or not to do more complex, longer valve sparing procedure, or just a quick aortic valve replacement or a bent valve procedure. So it does come into the equation for the decision of the surgery.
Thank you.
Any other questions? Okay, so I think, Anwar, you did a good job reviewing from the anatomy, pathophysiology, and the indications. I have very few points maybe to add, and I want to make sure all your colleagues understand it very well. So in terms of the anatomy of the aortic valve and the physiology of the aortic valve, it is more complex than the mitral valve. And that's why repairing an aortic valve compared to mitral valve repair is more complex. Mitral valve is a little more forgiving, okay? So in the aortic valve, you don't have chordae and papillary muscle supporting the leaflets. Instead, you have the aortic root and the physiology of the opening and the insertion of the leaflet. All these play a role. It's a tri-leaflet instead of bi-leaflet mitral valve. Just one second. Okay, sorry. So understanding when you're repairing for aortic stenosis, I don't think it does matter a lot. Aortic replacement is easy, and you guys are all exposed to it. When you're repairing the aortic valve, you really have to put all the physiology and the anatomy of the aortic valve into your mind in order to complete your repair. So Anwar elaborated on the leaflet insertion on the aortic valve, which is important. And can someone tell me exactly how is the shape of the leaflet insertion on the aortic wall?
It's semilunar.
Semilunar. So it's like a crown shape, right? It goes up and down. What is the top? What do you call the top area of insertion on the aortic valve?
The 3 edge or what?
It's not going to be the free edge. So it's a top. So if you imagine there's a free edge and there's insertion on the aortic valve, on the aortic wall, sorry. This insertion, if you cut the leaflet, you will see the insertion is going like a crown shape, like a semilunar, right? The top area, the commissure, excellent. So the commissure is the top area where the two leaflet insertions meet, correct?
Okay.
These
Yes.
are the commissures. If you draw an imaginary line connecting all commissures, this will be what level on the aorta?
The sinotubular junction.
The sinotubular junction. And what, you shouldn't be the one answering the questions, but excellent. So if you draw an imaginary line connecting all these three commissures, this will be your sinotubular, the level of the sinotubular junction, which is the end of the aortic root. So the aortic root is the area of the aortic wall between the ventricular aortic junction and the sinotubular junction. هذا هو definition حق aortic root. Okay, above the commissures are usually is the ascending aorta, above the sinotubular junction, right? The coronary buttons are within the aortic root, below the sinotubular junction, right? However,
Yes.
However, it's not uncommon that we see coronary ostia that are above the commissural level. So in other words, it's like coming from the ascending aorta. It's above the level of the sinotubular junction. And we see this mostly if there is an aortic dilatation. So as the aorta dilates, these ostia are pushed upwards and they become above the sinotubular junction, or they are congenitally developed like this. So they're born with ostia that are above the sinotubular junction. Okay. Now, if you follow the leaflet insertion on the aortic wall, the bottom side of the leaflet insertion, the lowest area, which is correlating to the middle of that insertion of each leaflet. فاهمين معايا؟ باكم تتخيلوا الكراون shape حق aortic leaflet insertion on the aortic wall. The top اللي هو فيه 3 منه هذه الكوميشنز. طيب the bottom اللي هو اوطى حته في الانسيرشن هذه in the middle of the leaflet insertion. What is it called?
Nadir.
The nadir of the leaflet insertion. Excellent. So this is the nadir. This is the lowest area of insertion of the aortic valve leaflet. Okay. In between the commissure and two nadirs, there's the interleaflet triangle. Can you guys imagine this? Sorry, we're just talking. Maybe if you Anwar put in any image that has the aortic anatomy, it will help a lot digest that anatomy. Okay, so the nadir. In between, yeah, put it back. In between the nadir, there are two nadirs and one commissure at the top. This is a triangle called interleaflet triangle, correct? Part of that triangle is in the aortic wall, and part of it, in fact, comes from the ventricular side, okay? Now the annulus, yes, so this is the interleaflet triangle, right? The annulus, the aortic annulus, there's no real circular annulus. Okay, there is a basal ring, which is an imaginary line connecting the nadirs, but there's no true annulus. The true annulus, it might be the insertion side, which is the semilunar or the crown-shaped insertion. Okay, so this is important to understand. Now, if you think of that area of the nadir, or what we call the basal ring or the annulus, okay, and the sinotubular junction, it's also important to understand there is a ratio, there's a normal correlation of these sizes. This also contributes to the function of the aortic valve function, okay? So the annulus and sinotubular junction size are correlated, very tightly correlated. In children, it might be around 1, so the ratio is 1:1. In adults, it does change. Why? Because the sinotubular junction dilates a little bit as you grow. Then it becomes around 1.2, 1.3. So the sinotubular junction is slightly bigger than the annulus, the true annulus of the aortic valve below. Okay. If you play with these dimensions, just by disturbing that relationship, you can cause aortic regurgitation, and that's the case of ascending aortic aneurysms. So in isolated ascending aortic aneurysm, which is an aneurysm above the aortic root, it can dilate the area of the sinotubular junction and therefore pull the leaflets outward and therefore cause aortic regurgitation. So an aortic regurg is not only seen in aortic root dilatation, you can also see it in ascending aortic dilatation. Okay. And by replacing your ascending aorta, you can fix that regurg without even touching the leaflet. You can fix that regurg just by reducing and restoring that ratio. Is that clear to everyone? The other thing is in isolated aortic valve regurgitation. So these patients has no aortic root dilatation, no ascending aortic dilatation, but they have to have an annular dilatation in order to cause an isolated aortic regurg. Otherwise, it has to be endocarditis or leaflet perforation. But for no leaflet perforation, لازم يكون في even at least an annular dilatation that distort the ratio and causes aortic regurgitation. So understanding these relationships, the anatomy of the root and the aortic valve is important when you're trying to the mitral valve repair concepts. Okay? Now, based on these that we talked about, you classify aortic regurg into 3 phenotypes according to the aortic phenotype. انت اللي تكلمتي عنها انوار كانت aortic phenotype في bicuspid aortic valve. Now, if we talk, no, you don't need to flip into that. If you talk about aortic regurgitation, you can classify it as Carpentier classification for mitral valve. So how do you classify mitral regurg? Carpentier classification, who knows them?
Normal leaflet and prolapse leaflet and restricted leaflet.
So class 1, class 2, class restricted normal leaflet motion prolapsing leaflet, huh? Like,
yes.
And same you can apply it here in the aortic valve leaflet. And these are classified بدل ما الكاربنتير عمل classification what's his name Al-Khoury and Budwani, they classified it as well, but it's too complex of a classification. So type 1 with normal cusp motion وهدول ايش حيكون؟ ما حيكون عندهم aortic dilatation. Okay. Anyways, this is a little too complex to describe. The easier classification is to look at the aorta. Okay, so if the aorta is normal, there is no root or ascending aortic dilatation, then then this is the normal aortic phenotype. Okay, and usually it's associated with what? ايش لازم يكون عشان يصير فيه regurg؟ يا leaflet perforation صح؟ يا annular dilatation. Okay, or there is a root dilatation phenotype or an ascending aortic dilatation phenotype, and each will have its own method of repair when you're addressing the aortic valve repair. Okay, is that clear to everyone?
Yes.
في أي سؤال على اللي قلناه so far? Anyone has a question so far? Okay. I think your colleague Anwar will talk about the guidelines. Is that correct?
Yes. The second lecture will be about the guidelines.
Okay, excellent. Because I was going to fault you for not mentioning the stages of stenosis and the eye based on the guideline stages. These are really important for your exam and the questions in the exam, okay? And I'll leave your colleague to talk about. And then the indications, whenever you talk about indications, it has to be guideline indication based. So it has to be on the basis of guideline class 1, class 2A, class 2B, and like that. Okay, you did that with the aortic regurg, but you didn't do that with the aortic stenosis. And I guess that's fine since your colleague will be talking about. We will not talk about that at the moment. for bicuspid aortic valve, the Seaver classification that you put in, you can put that please on the screen. So who can tell me what are the classification of bicuspid aortic valve before? Khalas, we put it in. So type 0, type 1, type 2. Okay, in type 0 there is no raphe, correct? So this is a true, easy to diagnose, easy to see on echo bicuspid aortic valve, right? You will see two nicely moving leaflets, and then a commissures that are oriented at what degree? A commissural orientation here, 180 degrees. صح? Okay.
Okay.
Okay. So in type 1, the difference here is that you have a raphe and the commissural orientation between the true commissures. And here I say true commissure, okay? Because there is a true commissure. And you see that raphe joining the right and left cusp here on the image? There might be the raphe, it may continue all the way to the leaflet insertion and cause a commissure. ممكن تعمل commissure في الليفلت صح؟ يشوف الكوميشر. ايش الفرق بين الكوميشر هذه والترو كوميشرز اللي هي الثانيين؟ What are the difference? Can someone tell me?
Maybe the movement during leaflet movement, it will not move if it is a raphe.
So yes, so it will be fused. You will see the fusion and all this. But how will you differentiate it from, let's say, calcification between two leaflets? صح؟ Calcification ممكن تبين كأنه the two leaflets are joined together. And you see that commonly when you're doing aortic replacements, that you see there are the leaflets are almost connecting together. What do you say this is a bicuspid or tricuspid valve? So the commissure here, it's not a true commissure. The insertion, the commissure, does not reach the sinotubular junction. So it's usually below the insertion points of the other leaflets. And that's another way also to diagnose it on echo and surgically. Okay? So here we know this is a unicuspid, bicuspid, or tricuspid aortic valve by looking at the commissural insertion. If it's below the true level of the sinotubular junction, this is not a true commissure. This is a fused commissure. Okay? And here with the raphe, you still can have a commissural orientation at 180 degrees. يعني كأنه type 0 اللي على اليسار هذا بس تشوف رافع. So that's very easy, right? The most difficult is when you have a shape حق tri leaflet, so a commissural orientation, two true commissures تكون oriented at 100 and what? Can someone tell me? ايش حيكون orientation هنا؟ It's not 180 degrees, it's 120. 120 degrees, excellent. So it will be 120 degrees, or it could be anywhere in between, okay? The difficulty is when it's at 120 degrees, then you are confused. Is this a fused cusp? Is this just calcification? Or what is that? And you identify it by looking at the commissure insertion on the aortic wall. All right. Okay. Now the type 2 classification, it's not really a bicuspid valve. I think it's a misnomer or a wrong classification because you're classifying bicuspid valve, but then you're saying this is a unicuspid valve. If you have a one single true commissure and two false commissures, this is a unicuspid valve, not a bicuspid valve. So a type 2 bicuspid is really a unicuspid valve, not a bicuspid valve. Okay. All right. I'm just mentioning all these because they are really taken into consideration when you're doing aortic valve repair as well. Okay. Okay. The last thing you mentioned, and it's very, very important for everyone to understand, is that you can have bicuspid aortic valve this bicuspid aortic valve will predispose the patient to two things in their lifetime, or three things in their lifetime. Can someone tell me what are the things that these patients are predisposed to?
Aneurysm, dissection, and aortic valve pathology.
Faisal, sorry, I got my connection was bad. I didn't hear your answer. Can you say it again?
Is it aortic aneurysm and dissection and aortic valve pathology?
Excellent.
And infective endocarditis.
So you can have aortic stenosis or premature aortic stenosis. These are similar to Dr. Anwar mentioned. It can happen 5 or 10 years earlier. Okay, so bicuspid aortic valve can have the normal calcification that elderly will have, but a little faster because of the anatomy of the bicuspid valve that predispose it to more forces, more friction, and more calcification over time. So then number one. But you can have no valvular lesion, but have aortic dilatation that predispose you to rupture and aortic dissections, right? Okay. And then we said we need to monitor or screen the patient, family, first degree relatives for what, Faisal?
I don't know, genetic mutations for connective tissue diseases or aneurysms.
So you don't do that yet. Okay, you don't send them for genetic screening because that's very expensive, complex, or not available in our own centers. What you do first is you screen them for presence of bicuspid aortic valve or what?
Aneurysms.
Or aneurysms. So not necessarily that the family member, the first degree member, will have bicuspid aortic valve, but surely they can have aortic aneurysms. Okay, so the genetic coding that coded for the presence of bicuspid valve in a certain patient can predispose a first degree relative to ascending aortic aneurysm without bicuspid aortic valve. Okay, so that's important to understand, and that's how we will discover and see more aortic aneurysms. Okay, by screening patients, because these aneurysms are usually asymptomatic. And the way that we pick them up early before they rupture or dissect is to screen patients for these problems. So هذه واضحة؟
Yes.
Okay, ممتاز. نتكلم على الأكيوت aortic regurgitation. When is it usually seen يا شباب؟ أبغى أحد يشارك من اللي ما شارك وما سمعنا صوته من الأول. When do you see acute aortic regurgitation? What are the causes usually?
Infective endocarditis.
So infective endocarditis is the number one cause for sure. So infective endocarditis تعمل perforation, تعمل acute severe aortic regurgitation. What else can cause acute or acute severe aortic regurgitation?
Dissection.
قالتها aortic dissection.
Inferior MI. Inferior MI.
No, MI. Why would an MI cause a severe acute aortic regurgitation? Can you say?
Yes. Again, what? Sorry, I couldn't hear you.
Why? Yeah. Why would an myocardial infarction cause severe aortic regurgitation?
Because of papillary
What would be
dysfunction. Papillary muscle dysfunction causes a rupture.
But which papillary muscle?
Posterior lateral muscle, because it's having only one source of blood supply.
So you're confusing aortic with mitral regurg. We're talking about aortic regurgitation. So I want you to think of aortic.
Yeah.
Okay.
Sorry.
So again,
got
so
confused,
as you just rightfully thinking of the mitral valve as mitral and ventricular disease. So a ventricular problem can cause a mitral disease like dilatation, rupture of papillary muscle, all this. I want you to look at the aortic valve as an aortic and aortic root disease or ascending aortic disease, correct? So yes, it doesn't have papillary muscles, but it does have the aortic wall and the aortic root to support it. So in case of aortic dissection, you have a rapid expansion of the ascending aorta or root with the dissection, or the flap itself, the aortic flap, can go down either dynamically through the aortic valve, but it prevents the aortic valve from closing, or by prolapsing, it prolapses the support for the aortic leaflet. الليفلت هذه تطيح كده ما في شيء ماسكها في الوال صح؟ فتعمل acute regurg. And in endocarditis or a dissection, these will just add to the burden of the disease. So the endocarditis are usually, these patients are septic, inflamed, whatever problem عندهم. With dissection, it's the same. Usually they have their own problems with dissection, and you add to it, and you can't compensate because now you have a problem with the aortic valve closing. So as Dr. Anwar mentioned rightfully, this is a very life-threatening problem. They don't tolerate that usually. Okay, and the most wrong answer that you can say in the exam, and you can fail your exam right away, is that you say you can insert or you should insert a balloon pump in acute aortic regurgitation. So in mitral regurg, can we put a balloon pump or not? Does it help putting a balloon pump in severe mitral regurg?
Yes, of course. Mitral, yes.
Of course. So, whereas in aortic valve, no, it would make it worse, and it's not the right answer. Okay. Like, and these patients are usually don't tolerate waiting. These are usually medical emergencies or surgical emergencies. You have to take them endocarditis. Like for endocarditis, once they develop severe regurg, just take them right away to the OR. Even if they're compensating a little bit, they won't compensate for long. So don't say the patient is stable now, that's fine. No. If it's a true acute regurg. Okay. واضحة؟
Yes.
طيب. All right. في other questions؟ أنا خلصت اللي عندي.
Yes, Dr. Mazen.
تفضل.
This is Luay. Just going back to bicuspid aortic valve, so you're suggesting that any patient with bicuspid aortic valve to send his first degree relatives for assessment of aneurysm? So,
yeah, this is not my suggestion. This is the guideline suggestion, by the way.
Yeah. I'm not sure, is this the current practice in our centers here in Saudi Arabia?
No, it's not. No, it's not. No, it's not. And that's why aortic aneurysms are underdiagnosed in I think in the region. We claim that the aortic aneurysms are not prevalent in Saudi Arabia, but only because we're not looking for them. If you're waiting for aortic aneurysms to rupture, you will not diagnose them. You won't know there is a prevalence or not of aortic aneurysms. You only know about them when you screen them the right way. Okay.
Thank you.
لؤي
تفضل.
يديك العافية دكتور مازن، يديك العافية
حبيبي. الله يسلمك.
الله يسلمك. أنا جوين قريب، ما كنت أدري إنك اليوم موجود، بس لؤي على
replacing Dr. Ghanem. And by the way, مبروك، ما لحقت أبارك لك على
الله يبارك فيك. أي حاجة
عقبال الشباب الباقيين إن شاء الله على خير إن شاء الله.
Inshallah. Regarding Luay, you mentioned one thing, that the current practice is not using this, and this is, as Dr. Mazen said, it's a guideline. Many surgeons, they do this regularly. Patient with bicuspid valve, even some surgeons, they do immediately CT. Even some of them, if the TE is showing clearly no dilated sinuses, they will not. Some of them, regardless, once there is bicuspid valve, they will go immediately to do CT aorta, just to exclude aortic dilatation and aneurysm.
Mm-hmm.
But not many surgeons I saw here, they are doing this. فما أعرف لو أي أنت كنت تقول the current practice they are not doing. So just be sure.
I think it does
this.
vary from center to center. I think it is variable, even from surgeon to surgeon, as you're saying, Haytham. I'm sure there are many surgeons who are following the thorough follow-up and screening. But the problem is not the surgeons, Haytham. I think the problem is that you see bicuspid valves in our practice most of the time when they reach the surgical indication. Correct me if I'm wrong. Okay, most of those patients are referred when they are symptomatic, when they have been discovered to have an incidental aneurysm or this or that, and by the time they reach you, they are maybe the minority of the bicuspid aortic valve that are seen in practice by cardiologists, by general practitioners. Okay, and that is the problem, is that those who are the ones that are not screening correctly for the we don't screen لما توقع الراس العصا الراس. يعني لما يجي البيشنت سيمتوماتيك كده نقول له اوه والله وي نيد انت تبغى لك عمليه، وكمان اهلك يبغى لنا وي سكرين ذم ات ذا مومنت وكذا، قده مريض خايف واهله خايفين، يمكن حتى يعني يهربوا من العمليه، عارف، ويهرب من يقول لك لا يا عمي انا ليش ادور وادور لي على مشكله. No, the practice is whenever you diagnose bicuspid valve as a practitioner, as a cardiologist, لازم تعمل الشيء هذا من بدري.
Yes. Unfortunately, in some cases, I saw the patient came, in the extreme spectrum at the end of bicuspidortic valve with with very dilated annulus, cooked ventricle, dilated ventricle in acute phase. I saw 2 cases like this, which even the surgeon will be thinking multiple times to take him or not to take him.
Yes, exactly. All right. Any other questions before we move to the next talk? طيب ممتاز. So I hope everyone understand the basic anatomy of physiology والحاجات هذه. These are very important. This is a super important topic in your practice, in your exam. I'm sure there is plenty of questions that can be asked to your colleague Haytham about this on that topic. So this is a major topic in our practice and the exam. Okay, so why don't we move to the next talk?
Not sure, Anwar, do you want to go through the questions or we can?
Oh yes, Anwar had some questions.
It's like 60 questions. You want me to go through them?
Sure. Let's go quickly. Yeah.
Okay, this is the first question. In the bicuspid aortic valve, the most common fusion of the cusp is along which one? A is the right and left cusp, B the right and non-coronary cusp, C the left and non-coronary cusp, and D left and the right coronary arteries.
Left and right coronary cusps.
Okay. The second question, which is false about the bicuspid aortic valve? A, it occurs in 1 to 2% of the population. B, usually lead to valve calcification over time. C, bacterial endocarditis can occur. D is associated with dissection of the descending thoracic aorta.
D.
Yeah. The third question, which is the first symptoms in patients with aortic stenosis?
Angina.
Angina, yeah. The fourth one is only Ayat is answering.
Yeah, let's have someone. I'll let you pick the one who answered the next question, Anwar. So you get to choose who answers the question to see if everyone is awake with us.
I don't want to choose, but if nobody is answering, I will choose.
No,
You
خلاص
are
Haytham, you get to pick who answered the next question. يلا يا جماعة.
The fourth question, you are suddenly called into the OR by the anesthesiologist. The patient was being put to sleep and he was arrested. The most common cardiac lesion to present in this way is AR, MS, AS, and MR.
دكتور عبير.
يلا يا دكتور عبير.
It's happened with aortic regurgitation.
Think again.
Why would it happen in aortic regurgitation?
Because the valve would not has the competency to close, like if it's the not under sedation.
No, but here you have to think of the physiology of the anesthesia. The sequence here, or the scenario here, is telling you you're putting the patient to sleep, and the patient arrested.
Aortic stenosis.
Aortic stenosis, excellent.
Yes.
Aortic stenosis, because what's the difference between both? In the aortic stenosis, you have the fixed. I mean fixed till اللهم صل على محمد cardiac output.
Yes, and this is actually important also, is that in real practice, maybe we don't do it. But I know most surgeons, the good surgeons, if it's tight aortic stenosis, okay, they are scrubbed while the patient is put to sleep.
Yes.
Because this does happen, and you really have to maintain good pressure. Once you lose the pressure, the problem with these patients, if they arrest, it's a big problem. Even if you do CPR, it's not that good of a CPR. The cardiac output is not as good. So yeah, you have to pay attention to that. Good question, yeah, Anwar.
Yes.
Next.
The fifth one is you are performing an AVR, an 80-year-old patient with severe AS. The operation went well. You were able to place a size 23 valve. You come off bypass, and in the next few minutes, the patient is hypotensive and need to go back on valve. You know that the coronaries are normal. The anesthesiologist tells you that there is now severe MR. This complication has occurred due to what?
عبد الله الشهري.
ترى في اثنين عبد الله الشهري. طيب
اكيد انت.
طيب this patient I think deep stitch to automitral continuity which between non-coronary and left.
Yes, so it is A.
Yes.
Good.
Yeah, the sixth question is 72-year-old with shortness of breath and the setting of aortic stenosis. Ask you how long am I going to live if I don't undergo surgery, if it is needed. So what is the right answer?
دكتور أحمد العمري. أو دكتور الجهيم، بس الدكتور أحمد مو موجود. فيصل الغامدي.
I think 2 years.
Yes, 2 years, because the patient is having symptoms of congestive heart failure. Yeah, that's it. Thank you.
Thank you, Anwar. Nice presentation.
يعطيكم العافية. يعطيك العافية دكتور أنوار. يا ما شاء الله. طيب, let's move on to the next topic.
Dr. Abir, are you ready or you need some time to?
No, I'm
prepare?
ready. Can you let me share screen, please?
Luay, no break?
Yeah, if it's a short break, please.
Yeah, please.
Can have 5 minutes break.
Sure, yeah, let's take a 5-minute break. Go ahead. So we reconvene at what? 3:10. Okay.
3:07. 3:10. Okay, sure.
Yeah, 3:10 we'll reconvene. Yeah.
السلام عليكم.
عليكم السلام ورحمة الله.
Anwar, I have a comment about the questions and the type of questions. May I?
Yes.
Please ask Luai to share with you the standards that the Saudi Council have set for the type of questions. Many of these questions are not acceptable for putting an exam because of the negativity in it, as well as the potential for, let's say, different opinions. And the last question, I think, was quite a tricky one. الحياة والموت بيد الله. بس to fix it on 2 years, I think it's kind of iffy. And you have to be careful when patients ask you this question. Thank you.
Okay, thank you, doctor.
I kind of disagree a little bit, especially your comment on the last question. In fact, the last question is very common in the exam scenarios, guys. It's not really to define that you have 2 years or 3 years to live. And the same applies to cancer patients, correct? So you don't say, wallah, you have 3 months to live. And they usually live 6 months and they tell you, wallah, the doctor was lying. It is based on the fact or on the curve that Anwar shared with you. And this is a common curve and common area of the exam. Okay, so the point here is not to say you have 2 years to live, it's to describe the data that we have in our hands. So to tell the patient based on data, you have a mean of 2 years to live once you develop symptoms. Okay, or you have 3 years or 5 years, depending on you have angina or CHF or this or that. Now, I think, yes, I agree with you. The type of question, these are not the exam type questions for sure. The exam questions are that has its own format. But I think the idea here of the exam is just to stimulate and see who was attending and following the basic points that we discussed in the lecture. But I agree with you. These are not exam type questions, that's for sure. يعطيكم العافية.
Dr. Abir can start.
Okay. Assalamu alaikum. Good afternoon, everyone. This is Abir Al-Ghamdi, R2 from King Fahd Medical City. Today, I will talk about the 2020 American College Cardiology and American Heart Association guideline for the management of patients with valvular heart disease. Specifically, I will talk about aortic valve. The 2020 has been released like 18 days ago. It's 13 days ago. It's 17 December. We'll start with general principles, with the evaluation of patients with known or suspected valve heart disease. Initially, for all patients, they have to go underwent a proper history and physical examination to establish symptom severity and comorbidities, valve disease presence and its severity, and presence of heart failure. Also to do transthoracic echo, which is the standard initial diagnostic test to establish chamber size, function, valve morphology, and severity, and the effect on pulmonary and systemic circulation. Also ECG for establishing the rhythm, LV function, and the presence or absence of hypertrophy. We will look for further diagnostic testing if we need more information for patients with equivocal symptom status, or there were a discrepancy between examination and the echo finding. So we'll go for chest X-ray. It's important for the symptomatic patient to establish the heart size and presence or absence of pulmonary vascular congestion, intrinsic lung disease, and calcification of aorta and pericardium. For further testing, also transesophageal echo. It will provide for us high quality assessment of native and prosthetic valve. It also includes definition of any intracardiac masses and possible associated abnormalities. We'll look for cardiac magnetic resonance to provide for us assessment of the LV volume and function, the valve severity, and if there is any aortic disease. We'll look also, we'll do order BITS CT scan. It aids us in determining if there is any active infection or inflammation. Also stress testing, it gives us an objective measurement of the exercise capacity. Catheterization, to provide us with measurement of the intracardiac and pulmonary pressure, valve severity, and hemodynamic response to exercise and drugs. To evaluate the patient regard the risk stratification, we use multiple tools like stress testing. It provides us with the prognostic markers. We use procedural risk like STS score to predict the risk mortality, and also TAVI score. Frailty score, it provides for us assessment of risk of procedure and the chance of recovery of quality of his life. Pre-procedural testing for every patient going for valve procedure, dental examination to rule out any potential infection sources, CT coronary angiogram or invasive coronary angiogram to provide an assessment of coronary anatomy if there is any ischemic heart disease, also CT peripheral to assess femoral access for TAVI and other transcatheter procedure, and CT cardiac to assess suitability for TAVI and other transcatheter procedures. For diagnosis and follow-up, the frequency of echo in asymptomatic patient with valve heart disease and normal left ventricle function, in patient stage B for aortic stenosis, and also aortic regurg, it's going to be every 3 to 5 years as the patient has mild severity of the disease. And for patient with moderate severity, they will go for every 1 to 2 years follow-up assessment with echo. In patient with severe asymptomatic, which is class C1, the patient with aortic stenosis will go for echo every 6 to 12 months, and for aortic regurgitation every 6 to 12 months. And if the patient have dilating LV, he will have to go more frequently to do echo. For evaluation of surgical and interventional risk, it's a class 1C for patient with valve heart disease for whom intervention is contemplated. Individual risk should be calculated, or specific surgical and or transcatheter procedure using online tool when available and discussed before the procedure as a part of shared decision-making process. For risk assessment for surgical valve procedure for patient to determine if this patient is low risk for surgical AVR or high risk or prohibitive surgical risk, he has to meet some criteria. We have 4 criteria here. The STS, which is predicted risk of mortality, and they can use also the Euroscore risk. There is also the frailty, which have 7 frailty indices, can be applied to calculate if there is no frailty or mild frailty or moderate to severe frailty. And the third criteria is cardiac or other major organ systemic dysfunction, like if the patient has cardiac, kidney, pulmonary, liver dysfunction, or cancer. And the fourth criteria is procedure-specific impediments. That means if the patient during the procedure will have tracheostomy or heavy calcified porcelain ascending aorta, chest malformation, arterial coronary graft adherent to posterior chest wall, and radiation damage. To say the patient is low risk for surgical AVR, he had to meet all criteria, which is STS less than 3%, and frailty and no frailty at all, and there is no cardiac or other major organ dysfunction, and there is no procedure-specific impediment. To categorize the patient as he's high surgical risk, he has to have 1 criteria from the 4 criteria, which is STS of more than 8%, or frailty has moderate to severe frailty score, or he has 1 to organ systemic dysfunction, or he has possible procedure-specific impediment. For prohibitive surgical risk, also he has to have 1 criteria. It's either STS risk score of more than 50% at 1 year, or he has moderate to severe frailty score, or he has more than 3 organ system dysfunction, and he has severe procedure-specific impediment. So the multidisciplinary heart valve team and heart valve center will decide the intervention for the patient. So patient with severe valve heart disease should be evaluated by a multidisciplinary heart valve team when intervention is considered. It's a class 1C, and consultation with referral to a primary or comprehensive heart valve center is reasonable, which is class 2AC, when treatment options are being discussed for patient with asymptomatic severe valve heart disease, or patient who may benefit from valve repair versus valve replacement, or patient with multiple comorbidities from whom valve intervention is considered.
Can I intervene, please? Sorry for being late.
Yes, sure.
Yeah, Dr. Mazen, he called me. He has something urgent, so I will be with you. He cannot continue the session. Sorry for that.
Okay, you're welcome, Dr. Aida.
تفضلي دكتور.
Okay, for timing of periodic imaging after valve intervention, initially post-procedure transthoracic echo is recommended for all patients, ideally 1 to 3 months after the procedure. Annual clinical follow-up is recommended annually for all the patients after valve intervention. Repeat imaging is appropriate at shorter follow-up intervals for patient with changing sign or symptoms during pregnancy, and to monitor residual or concurrent cardiac dysfunction. This is a class 1C. We'll go now for aortic stenosis. To stage a patient with valvular aortic stenosis, it should be classified ranging from patient at risk, which is stage A, or with progressive hemodynamic obstruction, which is stage B, and to severe asymptomatic, stage C, and symptomatic aortic stenosis, which is stage D. All of this can be defined according to the symptoms of the patient, valve anatomy, the severity of valve dysfunction, the response of the ventricle and pulmonary circulation. So for a patient with stage A, the valve anatomy will be in aortic stenosis if he has, the patient has bicuspid aortic valve or other congenital valve anomalies, aortic valve or aortic valve sclerosis. Valve hemodynamics, the aortic velocity will be less than 2 milli per second with normal leaflet motion. He will have no hemodynamic deterioration and no symptoms. For patients in stage B, which is a progressive aortic stenosis, patient will have mild to moderate leaflet calcification, fibrosis of a bicuspid or tri-leaflet valve with some reduction in systolic motion, or rheumatic valve changes with commissure fusion. The patient will have mild aortic stenosis, aortic velocity 2 to 2.9 millipersecond with main gradient pressure of less than 20. Or it will be moderate aortic stenosis with the aortic velocity 3 to 3.9 and main gradient from 20 to 39. Patient will have early LV diastolic dysfunction, and maybe he can have a normal LV ejection fraction. Patient will come with no symptoms. For asymptomatic severe AS, we can categorize them to C1 and C2. Class C1 is asymptomatic severe AS. The valve will be severe leaflet calcification, fibrosis, or congenital stenosis with severely reduced leaflet opening. Patient will have aortic velocity of more than 4 millipersecond or main gradient pressure of more than 40. The aortic valve area typically is less than 1 centimeter, and the very severe AS is an aortic valve maximum velocity of more than 5 millisecond or main gradient of more than 60. Patient will have hemodynamic consequences of that, LV diastolic dysfunction, mild LV hypertrophy, and maybe patient will come with normal LV ejection fraction. Patient may come with no symptoms, or when exercise testing is done, may confirm if any symptoms happen at that time. C2, which is asymptomatic severe AS with LV systolic dysfunction. Patient valve will have severe leaflet calcification or fibrosis or congenital stenosis with severely reduced leaflet opening. The aortic velocity will be more than 4 millipersecond or mean gradient pressure of more than 40. Aortic valve area typically less than 1. Left ventricle ejection fraction is less than 50% and still patient asymptomatic. For last stage is stage D, which is symptomatic severe AS. Patient can categorize we can categorize the stage D with D1, D2, and D3. D1, the patient with symptomatic severe high gradient AS. The valve will be severely calcified or has fibrosed or congenital stenosis with severely reduced the leaflet opening. Aortic valve velocity will be more than 4 millipersecond, or main gradient pressure will be more than 40. Aortic valve area typically less than 1. The patient will have left ventricle diastolic dysfunction or left ventricle hypertrophy, or pulmonary hypertension may be present. Will come with symptomatic exertional dyspnea, decreased exercise tolerance, or heart failure symptoms. He will come with exertional angina, exertional syncope, or pre-syncope. In stage D, which is symptomatic severe low flow, low gradient AS with reduced LV ejection fraction, the patient will have the same valve anatomy of D1. For the valve hemodynamic, the aortic valve area will be less than 1 centimeter with resting aortic velocity less than 4 millipersecond or main gradient pressure less than 40. With dupuytrenine stress echo, it will show aortic valve area of less than 1 with velocity of more than 4 at any flow rate. Patient will have left ventricle diastolic dysfunction, left ventricle hypertrophy, and his ejection fraction will be less than 50%, and he will come with heart failure symptoms, angina, syncope, or pre-syncope. The last stage of D3 is symptomatic severe low gradient AS with normal left ventricle ejection fraction or paradoxical low flow severe AS. The valve will come with severe leaflet calcification, fibrosis is with severely reduced leaflet motion. The aortic valve area will be less than 1 centimeter with an aortic valve velocity of less than 4 millipersecond or main gradient pressure less than 40. Stroke volume index will be less than 35 milliper-meter. The patient will have increase in left ventricle relative wall thickness, will have small LV chamber with low stroke volume and restrictive diastolic filling with ejection fraction of more than 50%. He will come with heart failure symptoms, angina, syncope, or pre-syncope. For initial diagnosis and follow-up of aortic stenosis, in patient with sign or symptoms of aortic stenosis or bicuspid aortic valve, Transthoracic echo is indicated for accurate diagnosis of the causes of aortic stenosis, assessment of hemodynamic severity, measurement of the LV size and systolic function, and determination of prognosis and timing of valve intervention. And this is a class 1A. In patient with suspected low flow, low gradient severe AS with normal left ventricle ejection fraction, which is stage D3, optimization of blood pressure control is recommended before measurement of the AS severity by transthoracic echo or transesophageal echo, cardiac catheterization, or cardiac magnetic resonance. It's a class 1B. In patient with suspected stage D2, a low dose dobutamine stress testing with echo or invasive hemodynamic measurement is reasonable to further define severity and assess contractile reserve. This is a class 2AB. In patient with suspected low flow, low gradient severe AS, which is stage D2 and D3, calculation of the ratio of the outflow tract to aortic velocity is reasonable to further define the severity. And this is a class 2AB. In patient with suspected low flow, low gradient severe AS with normal or reduced left ventricle ejection fraction, measurement of the aortic valve calcium score by CT imaging is reasonable to further define the severity, and it's a class 2AB. For the exercise testing, an asymptomatic patient with severe AS, which is stage C1, exercise testing is reasonable to assess physiological changes with exercise and to confirm the absence of symptoms. It's a class 2AB. And in symptomatic patient with severe AS, stage D1, exercise testing should not be performed because of the risk of severe hemodynamic compromise, and this is a class 3, which is harm. Medical therapy for patient with aortic stenosis. In patient at risk of developing aortic stenosis, stage A, and patient with asymptomatic aortic stenosis, stage B and C, hypertension should be treated according to standard guided directed medical therapy. It started at low dose and gradually titrated upward as needed with appropriate clinic monitoring. This is a class 1B. In all patients with calcific aortic stenosis, statin therapy is indicated for primary and secondary prevention of atherosclerosis on the basis of standard risk score. It's a class 1A. In patients who have undergone TAVI, ACE inhibitors and ARAP may be considered to reduce the long-term risk of all-cause mortality. It's a class 2BB. And in patients with calcific aortic stenosis, statin therapy is not indicated for prevention of hemodynamic progression of aortic stenosis. It has no benefit. So treatment of severe aortic stenosis with either a transcatheter or surgical valve prosthesis should be based primarily on symptoms or reduced ventricle systolic function. In adult with severe high gradient AS, stage D1, and symptom of exertional dyspnea, heart failure symptom, angina, syncope or pre-syncope, by history or on exercising testing, aortic valve replacement is indicated, and it's a class 1A. In asymptomatic patient with severe aortic stenosis and left ventricle ejection fraction less than 50%, aortic valve replacement is indicated, and it's a class 1B. In asymptomatic patient with severe AS, which is stage C1, who are undergoing another cardiac surgery, AVR is indicated. It's a class 1B. In symptomatic patient with low flow, low gradient, severe AS with reduced LV ejection fraction, aortic valve replacement is recommended at its class 1B. In symptomatic patient with low flow, low gradient, severe AS with normal left ventricle ejection fraction, aortic valve replacement is recommended if aortic stenosis is the most likely cause of these symptoms, and it's a class 1B. In asymptomatic patient with severe AS stage C1 and low surgical risk, AVR is reasonable when an exercise test demonstrates decreased exercise tolerance or a fall in systolic blood pressure of more than 10 from baseline to peak exercise. It's a class 2AB. In asymptomatic patient with very severe AS and low surgical risk, aortic valve replacement is reasonable. And it's a class 2AB. An asymptomatic patient with stage C1 and he's low surgical risk, aortic valve replacement is reasonable when the serum BNP level is more than 3 times the normal. And it's a class 2 AB. An asymptomatic patient with high gradient severe AS, stage C1, and low surgical risk, aortic valve replacement is reasonable when serial testing showing an increase in aortic velocity more than 0.3 millimeter per second per year. And it's a class 2AB. An asymptomatic patient with severe high gradient AS and a progressive decrease in ejection fraction on at least 3 serial imaging studies to less than 60%, aortic valve replacement may be considered, and it's a class 2BB. In patient with stage B, moderate aortic stenosis, who are undergoing cardiac surgery for other indication, aortic valve replacement may be considered, and its classes as 2BC. Now we'll see the choice of intervention, if the valve going to be mechanical versus bioprosthetic valve. In patient with an indication for aortic valve replacement, the choice of prosthetic valve should be based on a shared decision-making process that accounts for the patient values and preference and include discussion of the indication for and risk of anticoagulation therapy and the potential need for and risk associated with valve re-intervention. This is a class 1C. For patients of any age requiring aortic valve replacement, for whom vitamin K antagonist and anticoagulant therapy is contraindicated, cannot be managed appropriately, or is not desired, a bioprosthetic aortic valve replacement is recommended, and it's a class 1C. For patients whom less than 50 years of age, who don't have a contraindication to anticoagulation and require aortic valve replacement, it is reasonable to choose a mechanical aortic prosthesis over a bioprosthetic valve, and it's a class 2AB. For patients whose age 50 to 65 years of age, who require aortic valve replacement and who don't have a contraindication to anticoagulation, it is reasonable to individualize the choice of either a mechanical or bioprosthetic AVR with consideration of individual patient factors and after informed shared decision-making. It's a class 2AB. In patient who's more than 65 years of age, who require aortic valve replacement, it is reasonable to choose a bioprosthetic over a mechanical valve. It's a class 2AB. In patient with less than 50 years of age who prefer a bioprosthetic aortic valve replacement and have appropriate anatomy, replacement of the aortic valve by pulmonic autograft, the ROS procedure, may be considered at a comprehensive valve center. This is a class 2BB. Now the choice of intervention, if it's going to be surgical AVR or TAVI for patient whom a bioprosthetic aortic valve is appropriate. Their guideline in patient considering a bioprosthetic aortic valve replacement, the next step is the choose between TAVI or surgical aortic valve replacement. For symptomatic and asymptomatic patient with severe aortic stenosis and any indication for AVR who are less than 65 years of age or have a life expectancy more than 20 years, surgical AVR is recommended, and it's a class 1A. For symptomatic patient with severe aortic stenosis who are 65 to 80 years of age and have no anatomic contraindication to TAVI, either surgical AVR or TAVI is recommended after shared decision-making about the balance between expected patient longevity and valve durability. And this is a class 1A. For symptomatic patient with severe aortic stenosis who are more than 80 years of age, or for younger patient with a life expectancy less than 10 years and no anatomic contraindication to TAVI, TAVI is the recommended in preference to surgical AVR. It's a class 1A. For asymptomatic patient with severe aortic stenosis and an abnormal exercise test, very severe AS, rapid progression in disease, or an elevated in BNP, surgical AVR is recommended, and it's a class 1B. For patient with an indication for aortic valve replacement for whom a bioprosthetic valve is preferred, but valve or vascular anatomy or other factors are not suitable for TAVI, patient will go for surgical AVR. It's a class 1A. For symptomatic patient of any age with the severe AS and a high or prohibitive surgical risk, TAVI is recommended. If predicted post-TAVI survival is more than 12 months with an acceptable quality of life, this is a class 1A. For symptomatic patient who have severe AS for whom predicted post-TAVI or post-surgical AVR survival is less than 12 months, or for whom minimal improvement in quality of life is expected, a palliative therapy is recommended after shared decision-making, including discussion of patient preference and values. This is class 1C. So they will consider palliative therapy. In critically ill patient with severe AS, percutaneous aortic balloon dilatation may be considered as a bridge to surgical AVR or TAVI. This is a class 2BC. So for the choice of intervention, the balance between expected patient longevity and valve durability varies continuously across the age range, with more durable valve preferred for patients with a longer life expectancy. Bioprosthetic valve durability is finite, with shorter durability for younger patients, whereas mechanical valves are very durable but require lifelong anticoagulation. Long-term 20-year data on outcomes with surgical bioprosthetic valve are available. Other data on transcatheter bioprosthetic valve extend to only 5 years, leading to uncertainty about longer-term outcomes. The decision about valve type should be individualized on the basis of patient-specific factors that might affect expected longevity. Placement of a transcatheter valve require a vascular anatomy that allow transfemoral delivery and the absence of aortic root dilatation that would require surgical replacement. Valvular anatomy must be suitable for placement of the specific prosthetic valve, including annulus size and shape, leaflet number and calcification, and coronary ostial height. Examples of factors that favoring surgical AVR or favoring TAVI or palliative therapy instead of aortic valve intervention. Age life expectancy. If the patient is young and have longer life expectancy, he will go for surgical AVR. If the patient has older age, fewer expected remaining years of life, he's favored for TAVI. And if the patient have limited life expectancy, he's favored for palliative therapy. Valve anatomy, patient with bicuspid aortic valve or subaortic calcification, rheumatic valve disease, small or large aortic annulus will be in favor to surgical AVR. Patient who has calcific aortic stenosis of a tri-leaflet valve will be more suitable for TAVI. Prosthetic valve preference, mechanical or surgical prosthetic valve preferred in the surgical AVR. Concern for patient prosthesis mismatch. If there is annular enlargement might be considered. So patient will go better for surgical AVR. Favors for TAVI is the bioprosthetic valve preferred to use in TAVI. Favorable ratio of life expectancy to valve durability. TAVI provide larger valve area than same size in surgical AVR. Concrete cardiac condition, if the patient needed aortic dilatation or he has severe primary MR, severe coronary artery disease requiring bypass graft, septal hypertrophy requiring myectomy or AFib, he will go for surgical AVR, better for him. Patient with severe calcification of the ascending aorta, porcelain aorta, will be in favor to go for TAVI. And patient who has irreversible severe left ventricle systolic dysfunction, severe mitral regurg attributable to annular calcification will go for palliative therapy.
Yes, you can notice here, this is one of important table in the new guideline. Before we have high risk, intermediate risk, and low risk. It's not anymore in the guideline. When I'm talking about if you want to choose between SAVR and TAVR, now they went to the age immediately. They didn't mention high risk. However, they mentioned guideline. Patient to the high risk by STS score, it's better to treat him by TAVI. And especially the concern for the young if they need aortic root enlargement to have bigger prosthesis, because in the future, if you put valve in valve, that will further propagate the problem of patient prosthesis mismatch, because valve in valve, it will decrease more the actual size, the annulus size for that patient. And they are emphasized also in the guideline that for aortic stenosis patient, it is shared decision. All patients need to be discussing the combined meetings and to see what is the best option for them. Yeah, this is very summary about what Dr. Abir mentioned. This is different from updated 2017 guideline. If you have further question at this particular point, you can ask, or she can continue the lecture.
So Haytham, those changes will put the overall flow in favor of TAVI or SAVR?
This question, maybe we need more, another 5 years, because you know the result of the Partner 3 trial, it is only 1 year result. Partner 3, which is the low risk, SAVR versus TAVR. And remember that even Partner and the core valve trial was designed for patients with pure aortic stenosis with tri-leaflet valve, not bicuspid valve as well. And we have only 1 year. Other nowadays is more and more growing, and there is evidence about it in the TAVI, which is the valve thrombosis. Yani the leaflet itself in the TAVI, even the surgical valve, but it's more pronounced with in TAVI valve, maybe because in the guideline, the use of vitamin K is not just aspirin and Blavix for the TAVI. And this specific question, we need to see how the future will direct us toward what. According to guideline, if patient less than 65 years, it's and not high risk by STS score, it's better to do for him surgical valve, not the TAVI. But as technology is improving and evolving, we don't know what will happen after 5 years. Maybe it will decline, maybe it will be the same as with the stent. If you remember in the syntax trial initially, when they published the first year, there was a big something like celebration from the cardiology that CABG is halas, no more CABG in the world. And with the follow-up, everything was more clear when we have further data of the follow-up. So to answer your question, scientifically, we need the result. I cannot predict what will happen. Is it clear for you?
Yes, it's clear. But Haytham, my question was actually those changes in the guidelines, how it will change the practice, not the results, not the studies, but those changes in the guidelines, how it will change the decisions of the cardiologists, cardiac surgeons. Will it help the cardiologists to push for more TAVIs, or will it?
Yes, if any patient above 65, I think it will be like default, any patient 68, 70, not by default, but it will be, the patient will be pushed more toward the TAVI, because in the guideline, 65 to 80, it can go either way. They didn't mention, and giving that he's not high risk by STS score, which is actually the current practice nowadays is like this.
I see. Yeah. Okay, thank you.
But the problem, the issue with the younger patient, will you go for TAVI or not? And you have to calculate. Younger, that means he need another intervention, valve and valve. Yani, if the decision just for you, you need to check the annulus size, all these issues. Even if you don't need to do annular enlargement, but if you measure it, it is small, but it's not small to the extent that will cause patient prosthesis mismatch. You have to think, okay, I will give him TAVI. If I put valve and valve or another valve and valve, at that time, when he's old, I need to do for him surgical explant the TAVI and put surgical valve. You get the point? So you need to think ahead about what will happen. This is
I think, I think mainly when it comes to young population, I think the big difference between the TAVI and the surgical is the surgical you can put a mechanical, unlike the TAVI, it's a bioprosthetic.
Yes, and remember
valve.
the aortic stenosis is the pathology of aortic stenosis. It came with aged people, and usually with someone above 65 and above 60. It's not a disease for young people.
Yes.
The natural history of the disease.
Yeah. What about the bicuspid? I hear some cases being done for bicuspid TAVI.
It is being done for bicuspid aortic valve, and it is not recommended before in the guideline. Actually, in that all the trial was done for patients with Inter-Leaflet aortic valve, not bicuspid aortic valve. But there is a lot of publication about the result of bicuspid aortic valve. They have a higher chance of pacemaker implantation, as well as higher chance of complication or valve in valve in the same setting. The trick with the bicuspid aortic valve is how exactly, because the annulus is not the same shape as the annulus with the tricuspid valve. So you need experts cardiology to perform TAVI for bicuspid aortic valve, and to be aware about the pitfall in that procedure. There is many publication behind the scope of it is a talk by itself, but it's been done. It was used out of label for long time. Imagine if you have a patient with bicuspid aortic valve and high surgical risk, STS score, let's say 12 or 14. Of course, you will go for TAVI. So this is why nowadays TAVI, even for bicuspid aortic valve, it's been utilized. It has different technical aspect need to be aware of when you perform that, when you implant that valve, deploy that valve, sorry. This answer your question?
Yes, it answered. Thank you for the discussion.
Okay.
Haytham?
Hello.
So I have just a concern. Whenever you read these guidelines, you will see that they emphasize on multidisciplinary meeting or combined meeting. But in real life, at least in our hospital, when you attend these meetings, whenever you start arguing with the cardiologist about the patient is low risk for surgery, they will just end up the discussion by this is the patient choice. And then you have to give up because the patient has chosen to go for TAVI. So I'm not sure, should we change the practice to have a combined clinic maybe to explain for the patient, because he will hear it from one side only. So maybe he will go ahead with the TAVI.
Yes, of course. And if you told the patient you have surgical, I will crack your chest or put the valve through the groin, he will choose the TAVI. This is logic. And it is not about the patient choice is very important, but that practice need to be changed. To offer patient TAVI and he's not candidate for TAVI, you are harming him. If the patient is young with a small, let's say 40 years old, with a relatively small aortic annulus, you will harm him, because within 10 years, especially we don't know the follow-up of the TAVI valve. However, surgical valve in young patients, they will last, if they are really like 15 years, and the new valve, they have better durability. But if you're talking about average, you're talking about 7 to 10 years. Depend also on the activity of that patient. there is multiple factors can affect the durability of the valve, either biological valve or the mechanical valve. And the best things, you need to discuss it by evidence-based with the cardiology, with anybody. Be calm, discuss it in scientific way. This is 1, 2, 3. And if you find that the practice is going against the evidence, you can rise this up. I mean, in the administrative, you will rise it as an administrative to the director or to the higher authority, because that will harm the patient if there is harming for the patient. You get the point? The choice for the patient need to be respected, and it's very important, and is emphasized on all guidelines. But for example, patient need mitral valve repair and he want to do for MR, and he said, I don't want surgery, I want mitral clip. Mitral clip, it's an option, but not an option for you for myxomatous mitral valve. It should not be on the table as an option for the patient. The same with a TAVI. It should not be an option from the cardiology. I'm talking low evidence base, but if there is a problem, if you have a problem in discussion, problem in the unscientific discussion, this is a different issue. And you need to try to solve it in good way, otherwise you rise the issue. This is how I see it.
Haytham, the AF
yes?
favors SAVR, so that a maze can be done. Why in AF?
Atrial fibrillation favoring SAVR because it's combined procedure. It's not one procedure.
It depends if it's long term. Yeah, but yeah. So it's so that a maze can be done if indicated. Okay.
Yeah, maze, because you need to do the maze is full maze, left-sided maze. Usually is a full maze. The patient will benefit from it. So you go with a surgical AVR and you do the maze in the same setting. So it need to be done surgically. With any concomitant procedure, you will go with AVR, surgical AVR, not with TAVI. Clear?
Clear.
Luay, it was clear for you?
Yeah, I think Dr. Farid has comment.
Yeah, if he's with us, he can, of course.
السلام عليكم.
والسلام ورحمة الله.
أرجو ما تنزعج من كلامي يا هيثم وتترك المجموعة بعدين.
لا ولو أستاذنا يعني إحنا نتعلم منك.
جزاك الله خير. لا بس يعني okay, so the concern of I think is valid. Yes, we see, unfortunately, we see the team dynamics being affected sometimes by other interests. What I think would control things like this, there are three issues. First of all, the ethics of the team. Each one of you should really hold high on the ethical standards whenever we talk about patients. So if you're involved in one of those teams, find a way to communicate your concern to the person involved or to the chairman or whatever. Another control on those topics is, for example, in the US, if it's done in a way that is unethical, it will catch up with them in no time in the court space. So people will find themselves in court and they have to defend themselves and they have to ask this help of the surgeon to support their decisions. And if that comes up from what they call an expert witness, it may put a big burden on them. So everybody is there trying to adhere to the guidelines and adhere to the ethical principles, mainly because they are afraid from the lawyers. What's happening in our space is that the limitation that's put by the administration on how much expenses you can have in this project is also limiting. So we have maybe every year about 150 to 200 patients who undergo aortic valve surgery, but we don't have that resources for the TAVI. So we end up doing maybe 30 or so per year of TAVI. Again, just by looking at the numbers and the aging population, I think at the end, you will have enough practice in your hand to not make a big fuss out of this. But of course, it will come up in mortality, morbidity, and redos, and long-term follow-ups, and registries. So the best way is after ironing out all the ethical issues that you're talking about, is to make sure that you have good communication with your team members at a different level. It should be professional communication, though you disagree with them and things like this, but you should come up, just like Haytham said, evidence-based discussion and presentations, or even closed door small committees and things like this. Hopefully it will iron it out. If you stand alone, being stubborn person, though you may have good ideas in your brain, you may suffer as a person, as a surgeon. So please always play it politically right, along with the other team members. So that's about your concern. The other concern was mentioned about atrial fibrillation. Well, there are other issues that you can deal with atrial fibrillation, and the indication for bicuspid valve, for example. Yeah, it has been done, but again, anytime you deviate from the standard of care, for example, doing TAVI on a low-risk patient, you are liable, and you may not find enough support if it goes to court. So, and things are not very rosy on that direction. So you have to be really careful. Even atrial fibrillation can be managed by catheter with good success rate in the range of 70 to 80%. So I wouldn't throw it away. But if the patient require anticoagulation, that may be a different reason that commitment of another procedure may be indicated for those patients. Okay, those are my comments. Thank you.
Thank you, Dr. Farid. Roy?
Yes, Abir, you can proceed. Yes.
No, just to give you the leading position.
Yeah, تفضل Abir. Thank you.
Oh, okay. So we'll go back again to the examples of factors favoring surgical AVR. A patient who has non-cardiac condition, he will be favored for surgical AVR. A patient who has severe lung, liver, or renal disease, mobility issue, high procedure risk with sternotomy will be favored for TAVI. A patient who has symptoms likely attributable to non-cardiac condition, he has severe dementia or moderate to severe involvement of more than 2 other organs, will be in favor to palliative therapy. Patient who has no frailty or has few frailty measurement will be in favor to surgical AVR. TAVI, it's frailty likely to improve after TAVI. Patient will be favored to go for TAVI. Severe frailty unlikely to improve after TAVI. Patient will be in favor to go for palliative therapy. Estimated procedure or surgical risk of surgical AVR or TAVI. If the surgical AVR is low risk and the TAVI is high risk, patient in favor to go to surgical AVR. With patient who has TAVI risk low to medium and surgical AVR is high to prohibitive, it will be in favor to go for TAVI. Patient who has prohibitive surgical AVR risk more than 15% or post TAVI life expectancy less than 1 year will be in favor to palliative therapy. procedure specific impediment like valve anatomy, annular size, or low coronary ostial height preclude the TAVI, and vascular access does not allow transfemoral TAVI, patient will be in favor to go to surgical AVR. Patient who has previous cardiac surgery with at-risk coronary graft or previous chest elevation will be in favor to go to TAVI. Patient who has valve anatomy, annular size, or coronary ostial height precludes TAVI, or vascular access does not allow transfemoral TAVI, so he will be, and he is not suitable for surgical AVR, he will go for sure for palliative therapy. Now we'll go to the aortic regurgitation.
Sorry, I'm very sorry to interrupt. Can you please just go back for one slide?
Sure.
Yeah. So in case the access is not possible through a femoral for peripheral artery disease, palliation is an option. What about transfemoral, transaortic, transaxillary? I don't understand this. Haytham, I don't know if you can.
Which
like the last box on the right side, the
valve anatomy, annular size, or coronary ostial height precludes TAVI.
That's fine.
Okay.
The next one.
Okay. Vascular access does not allow transfemoral TAVI.
Yeah, it favors palliation. So what about the other option?
Yes, it's you will not take it only that the transfemoral access is not available, so I will go immediately, or you will go immediately to palliative therapy. You need to check the other access. You need to check the patient anyway. When they wrote, if you read in the guideline, you read this is only the box. If you go and read the details before coming to this point, you need to have a combined meeting, discuss everything. And for example, I was in my training for preparing the TAVI surgeon, the TAVI case. The case first discussing combined meeting, general, everybody is there. Then there is a TAVI meeting. Okay, in that TAVI meeting, the CT core valve will be done for the patient. I mean CT core valve from the aorta till down till the femoral bifurcation, and all the investigation, everything, variety of the patient, everything is there. Cardiac surgeon, 2 or 3 cardiac surgeon in that meeting. All the interventional is there, and 1 echocardiographer or 2 is in that specific TAVI meeting or TAVI team. So they discuss all the aspect about that patient, if he need to go for palliative or he needs the intervention, SAVR or TAVR. If it is TAVR, okay, the axis, the favorable axis is transfemoral, because in the study, other axis is showing increased morbidity and mortality, which is transaortic, transapical, all that increased mortality and morbidity. So to end up to have palliation therapy alone, that means there is all the other axis is not available for this patient, or the risk and benefits for going to that other alternative axis is not good, because if you see all the literature, apart from the transfemoral, transapical, and transaortic, give you high morbidity and mortality. This answer your question and concern or not?
Yeah, I think it does. So I believe, as you said, maybe probably in the details and the guidelines they have more. It's just that the how they phrased it in this box probably misleading. But as long as I think we agree on the point. Thank you.
But you understand the point of coronary ostial height and all that, because you will have.
Yes.
Okay, خلاص.
What do we mean by palliation? Is it the optimizing medical therapy?
Yes.
Okay.
So for these boxes, we are just mentioning examples of factors that favoring this kind of intervention, not a criteria. We'll go for aortic regurgitation. Stages of chronic aortic regurg. We have 4 stages, stage A, B, C, D. Patient with stage A still at risk of aortic regurg. Valve anatomy will has bicuspid aortic valve or other congenital valve anomalies, aortic valve sclerosis, disease of the aortic sinuses or ascending aorta, history of rheumatic fever or non-rheumatic heart disease, infective endocarditis. Patient will have none or some trace of aortic regurg severity with no hemodynamic consequences and no symptoms. In patient with stage B, will have same valve anatomy, but regard the dilated aortic sinuses, rheumatic valve changes, previous infective endocarditis. But regard the valve anatomy of the bicuspid aortic valve, it will be mild to moderate calcified of a tri-leaflet valve or bicuspid aortic valve. Hemodynamics in mild aortic regurg, the jet width will be less than 25% of the LVO2. Vena contracta will be less than 0.3 centimeter. Regurgitant volume will be less than 30 ml per beat. Regurgitant fraction will be less than 30%, and the effective regurgitant orifices will be less than 0.1 with angiographic grade 1. This is for the mild AR, and for the moderate AR, the jet width will be 25 to 64% of the LVO2, and vena contracta will be 0.3 to 0.6 centimeter with regurgitant volume 30 to 59, and regurgitant fraction 30% to 49%. And effective regurgitant orifices of 0.1 to 0.2 with angiography grade 2. Patient will have normal LV systolic function, or will be there is some mild LV dilatation. Patient will be at this stage with still with no symptoms. For stage C, which is asymptomatic severe aortic regurg, patient will have calcific aortic valve disease, or will come with bicuspid valve or other congenital abnormalities. Patient will may have dilated aortic sinuses or ascending aorta. All of these risk factors to develop asymptomatic severe aortic regurgitation. Rheumatic valve changes, infective endocarditis with abnormal leaflet closure or perforation. In severe AR, in the echo finding, we'll find jet width of more than 65% of the LVO2, vena contracta more than 0.6, regurgitant volume more than 60 ml per beat, and regurgitant fraction more than 50%. Estimated the regurgitant orifices will be more than 0.3 with angiography grade 3 to 4. In addition, diagnosis of chronic severe AR required evidence if there is LV dilatation or no. Hemodynamic consequences for C1, patient will be with normal left ventricle ejection fraction more than 50% and mild to moderate LV dilatation. End systolic diameter will be less than 50. For C2, patient will have abnormal left ventricle depression. Ejection fraction will be less than 55%, or has severe LV dilatation. End systolic diameter will be more than 50. And patient will come with no symptoms, or if he done exercise testing, it will be reasonable to confirm if the symptom status. For stage D, it will have the same valve, it's symptomatic severe AR. It will have the same valve anatomy and valve hemodynamics for category C. Hemodynamic, patient will have symptomatic severe aortic regurg, may occur with normal systolic function more than 55, mild to moderate LV dysfunction, or come with severe left ventricle dysfunction less than 40%. Patient will come symptomatic with exertional dyspnea or symptom of angina or more severe heart failure symptoms. To diagnose patient with chronic aortic regurg, in patient with sign or symptom of AR, transthoracic echo is indicated for assessment of the cause and severity of regurgitation, left ventricle size and systolic function, prognosis and timing of valve intervention. It's a class 1B. In patient with bicuspid aortic valve or with non-dilatation of the aortic sinuses or ascending aorta, transthoracic echo is indicated to evaluate the presence and severity of aortic regurg, and it's a class 1B. In patient with moderate or severe aortic regurg and suboptimal transthoracic echo images or there were a discrepancy between clinical and echo findings, a further diagnostic test like transesophageal echo and CMR or cardiac catheterization is indicated for the assessment of LV systolic function, systolic and diastolic volume, aortic size, and aortic regurg severity. This is a class 1B. So the indication for intervention for patient with valve regurgitation are to relieve of symptoms and to prevent of the irreversible long-term consequences of left ventricle volume overload. In medical therapy for patient with chronic aortic regurg, an asymptomatic patient with chronic aortic regurg who's stage B and C, treatment of hypertension if systolic blood pressure more than 140 is recommended. It's a class 1B. In patient with severe aortic regurg who have stage C, 2 and D, but a prohibitive surgical risk, guided directed medical therapy for reduce the left ventricle ejection fraction with ACE inhibitors, ARBs, and valsartan is recommended. It's a class 1B. So timing of intervention for patient with chronic aortic regurg. In symptomatic patient with severe aortic regurg who's stage D, aortic valve surgery is indicated regardless of the left ventricle systolic function. It's a class 1B. An asymptomatic patient with chronic severe aortic regurg and left ventricle systolic dysfunction less than 55%, aortic valve surgery is indicated if no other causes for the systolic dysfunction is identified. This is a class 1B. In patients with severe aortic regurg, stage C or D, who are undergoing another cardiac surgery for other indication, aortic valve surgery is indicated. It's a class 1C. In asymptomatic patient with severe aortic regurg and normal left ventricle ejection fraction, AVR is reasonable when the left ventricle is severely enlarged. If the end systolic diameter is more than 55, it's a class 2A level AB. In patients with moderate aortic regurg, stage B, who are undergoing cardiac or aortic surgery for other indication, AVR is reasonable. It's a class 2AC. In asymptomatic patient with the severe aortic regurg and normal left ventricle systolic function at rest, stage C1 and low surgical risk, AVR may be considered when there is a progressive decline in the left ventricle ejection fraction on at least 3 serial studies to the low normal range, or a progressive increase in the left ventricle dilatation into the severe range. Left and diastolic dimension is going to be more than 65. This is a class 2B level B. In patients with isolated severe aortic regurg who have indication for surgical AVR and are candidate for surgery, he's a class 3-4 TAVI. So in summary, patient with aortic regurg who has severe aortic regurgitation, who is symptomatic and the stage D, he go for AVR, it's a class 1. Patient who's asymptomatic, stage C, and with ejection fraction of less than 55%, stage C2, he go for AVR, it's a class 1. Patient who's asymptomatic, stage C, and he has other cardiac surgery indication, he can go for AVR and it's a class 1. For patient with stage C, AR and left ventricle ejection fraction of more than 55% or left ventricle end systolic diameter more than 50, he can go for AVR, it's a class 2A. With patient with stage C aortic regurgitation, asymptomatic, who has progressive decrease in the left ventricle ejection fraction to less than 55 to 60, or there is increase in the left end diastolic diameter to more than 65 on at least 3 studies, and the patient is low surgical risk, he can go for AVR and it's a class 2B. For patient who has moderate aortic regurg and he is going for another cardiac surgery, he can go for concomitant AVR and the other surgery, and it's a class 2A. We'll talk about the bicuspid aortic valve. Initial diagnosis for bicuspid aortic valve, and patient with known of bicuspid aortic valve, transthoracic echo is indicated to evaluate the valve morphology, measure the severity of AS and aortic regurg, assess the shape and diameter of aortic sinuses and ascending aorta, and evaluate for the presence of aortic corrugation for prediction of clinical outcome and to determine timing of intervention. It's a class 1 level B. In patient with bicuspid aortic valve, cardiomagnetic resonance angiography or CT angiography is indicated when morphology of the aortic sinuses or sinotubular junction or ascending aorta cannot be assessed accurately or fully by echo. It's a class 1C to ask for CT angio or CMR angio. If the views in the echo it's not accurate. In first degree relative of patient with a known bicuspid aortic valve, a screening transthoracic echo might be considered to look for the presence of a bicuspid aortic valve or asymptomatic dilatation of the aortic sinuses and ascending aorta, and this is a class 2B level B. So replacement of the aorta in patient with bicuspid aortic valve, according to the guideline, in asymptomatic or symptomatic patient with bicuspid aortic valve and a diameter of the aortic sinuses or ascending aorta is more than 5.5 centimeter, operative intervention to replace the aortic sinuses and or the ascending aorta is recommended, and it's a class 1B. In asymptomatic patient with a bicuspid aortic valve and a diameter of the aortic sinuses or the ascending aorta of 5 to 5.5 centimeter, an additional risk factor for dissection like family history of aortic dissection, aortic growth rate more than 0.5 centimeter per year, or he has aortic corrugation, operative intervention to replace the aortic sinuses and or the ascending aorta is reasonable if the surgery is performed at a comprehensive valve center. It's a class 2A level B. In patient with bicuspid aortic valve with indication for surgical AVR and a diameter of the aortic sinuses or ascending aorta is more than 4.5, replacement of the aortic sinuses and or ascending aorta is reasonable if the surgery is performed at a comprehensive valve center, and it's a class 2A level B. In patient with a bicuspid aortic valve who meet criteria for replacement of the aortic sinuses, valve sparing surgery may be considered if the surgery is performed at a comprehensive valve center, and it's a class 2B level C. In asymptomatic patient with a bicuspid aortic valve who are at low surgical risk, have a diameter of the aortic sinuses or ascending aorta of 5 to 5.5 centimeter, and patient have no additional risk factor for dissection, operative intervention to replace the aortic sinuses and or the ascending aorta may be considered if the surgery is performed at a comprehensive valve center. So in summary, patient with bicuspid aortic valve who has aortic sinus or ascending aortic diameter more than 5.5 centimeter, patient is a class 1 to replace aortic sinuses and or ascending aorta, and for valve sparing may be considered at a comprehensive valve center. It's a class 2B. For a patient who has aortic sinus or ascending aortic diameter of 5 to 5.5 centimeter with risk factor for dissection, replaces the aortic sinuses and or ascending aorta at a comprehensive valve center is a class 2A, and for valve sparing surgery may be considered at also a comprehensive valve center. It's a class 2B. For patient with indication for surgical AVR and he has bicuspid aortic valve and aortic sinus or ascending aorta diameter of more than 4.5 centimeter, replace aortic sinuses and or ascending aorta at a comprehensive valve center is a class 2A, and for valve sparing surgery may be considered at a comprehensive valve center is a class 2B. For aortic sinus, for patient with bicuspid aortic valve and aortic sinus or ascending aortic diameter 5 to 5.5 without risk factors for dissection, like family history or something, replace aortic sinuses and or ascending aorta if performed in low risk patient at comprehensive valve center is a class 2B. And for valve sparing surgery, it may be considered and it's a class 2B. Repair or replacement of the aortic valve in patient with bicuspid aortic valve and severe aortic regurg who meet criteria for aortic valve replacement, aortic valve repair may be considered in selected patient individualized if the surgery is performed at a comprehensive valve center. It's a class 2B level C. In patient with bicuspid aortic valve and symptomatic severe aortic stenosis, TAVI may be considered as an alternative to surgical AVR after consideration of patient-specific procedural risk, values, trades-off, and preference, and when the surgery is performed at a comprehensive valve center. It's a class 2B, level B. Thank
you. Thank you, Dr. Abir. If you have any question, you can ask Dr. Abir.
Thank you, Abir. Nice presentation.
Thank you.
Okay, I believe no one has a question. So thank you for joining us today, and we'll see you next week, inshallah. Thank you, Haytham.
Anytime, and if you have anything, you can reach me at any time through WhatsApp. I answer. Don't.
شكرا جزيلا يعطيك العافية.
العفو. مع السلامة. One thing, kindly, for who still in the group, I will send you today, because Mazen raise one question regarding patient with severe aortic stenosis when anesthesia induction started and he will be arrested. So one of the podcasts from the TSRA, I will send it to you. It's very nice. I think it's 40 minutes, 30 minutes. You can listen to it at any time. Very nice, stepwise, what to do with patient with severe aortic stenosis and as well as patient with a left main disease. When you have patient arrested in the OR, the question was patient arrested in the OR, what to do. So I will send it in the general group. Thank you.